We got a few stragglers that'll be coming back, but we're going to continue our conversation. We've got a lot of field to plow yet this afternoon, and so we're going to get at it. We left with Mrs. Butler getting ready to talk to us about the draft bill and language on that we need to do for the treatment courts. So Alyssa, if you wouldn't mind, would you kind of give us a start down that path and give us the explanation, and then we will get ready to have staff present the bill and work it, okay?
Mr. Chairman, members of the task force, Elisa Butler, State Court
And
Administrator.
Elisa, we'd like you to even get closer than that to the mic.
Elisa Butler, State Court Administrator for the Wyoming Judicial Branch. So this bill, or the language in this bill came from the treatment court committee that was created and that we've worked with over the last year or so. These are some of the areas of need that was identified by that committee for statutory changes in order to allow for treatment courts to operate in a different way, maybe more effectively, maybe more efficiently in some of these. And Mr. Chairman, I'm not sure if you want me to wait to talk about the explanation for each of the changes after we walk through the bill, or if you want me to give you a high level.
I would
overview.
prefer that we do it now, and you may find
Okay.
that you're doing it twice as some of
Okay.
our other members show up, but
Perfect.
let's do that and see how you adjust it, and then we'll walk through the bill.
Okay.
Staff, okay?
Mr. Chairman, looking first to section 512-108. The reason for this change really would be to allow for regional treatment courts. What we find in some of our communities is that they are too rural for each county to have its own treatment court. And so this would allow for 2 or more counties or municipalities or tribes 501c3 to create a regional treatment court that wouldn't just serve one location, it could serve multiple locations at the same time. So the next change.
So can I ask a question on that?
Mr. Chairman, yeah.
So if tribal governments was left out, does that prohibit them in tribal court to have treatment court? What's the purpose of having the tribal courts in there?
Mr. Chairman, in this specific amendment, this would allow the tribes to coordinate to create a regional treatment court that could cover both. So if they were left out, currently, the way that the statute reads, there is no specific provision that allows for 2 government or 2 entities to come together to create a regional court. And so that really is the purpose behind this statutory amendment.
And I appreciate that, but we find sometimes that we have a difference between the Tribal Law and Order Code and state statute.
Mm-hmm.
And so if there is regionalized treatment court, what statutes prevail?
Mr. Chairman, I'm not sure. And so I think one of the questions around this statutory change would be within the statute itself, it doesn't specify how a regional treatment court would operate. And so within the statutes, there's a provision that says the staff should work for the treatment court and paid through the treatment court. And so those 2 coordinating entities would have to determine how that would work.
So if I understand you correctly, then there's flexibility for the treatment court to conform to what the respective jurisdiction would require.
Mr. Chairman, that's correct, yeah.
Okay, very good, thank you.
Mm-hmm. So moving on to 512-109, so you'll find some language there in subsections A, Romanet I, and A Romanet II, and really those 2 are designed to allow a defendant to exercise his or her right to a trial and still allow them to participate in treatment courts. So if they go through a trial, they're found guilty, and the judge upon sentencing determines that they can still go through a treatment court, that would be allowable with this amendment. Without this amendment, if you are found guilty, you cannot participate in treatment courts.
Okay.
Mr. Chairman, subsection C under that, this really is conforming in my mind, and what it does is In Title 14, there is a language in that statute that allows a judge to order a juvenile or the juvenile's family to treatment court without consent. So the judge can require that without consent under Title 14. And so what this does is it just marries up that language.
Yeah, we kind of had to play with that a little bit, but I think we landed where we needed to be.
Mr. Chairman, I think that's right.
Well done, Anna.
And then moving on to subsection E within that statute, currently, I think the assumption is that when a treatment court is created, that it serves the residents of that county. Generally, there are other treatment courts that serve, municipalities, but generally what the assumption is that they will serve the residents of that location, wherever the treatment court is located. What this amendment does is it allows for the treatment court to take participants from other locations. So even if a person is not a resident of the county, the treatment court could take that person as a participant. It would still be the same process. They would not be required to take that participant. It would have to be the treatment court team's decision and recommendation as to whether or not a participant would be included, but it allows for that flexibility.
And then your jurisdictions would work out the details on costs associated with taking somebody from another jurisdiction or not. That flexibility is left with them, and if they're fine with doing it at no cost, so be it. But we're not dictating that component, right?
Mr. Chairman, that's correct.
Okay.
And then the last one is in Title 7, 76104, and that amendment really is designed for the public defender. So currently, there's no explicit authority for the public defender to participate either in treatment courts or the diversion court. And so this just gives the public defender explicit authority to participate. And I think that was at the request of the public defender's office because of some liability issues that they wanted to make sure were covered. So, Mr. Chairman, that's the intent behind those amendments to the statutes, and I'd be happy to answer any questions.
Mr. Speaker and Senator Barlow, we just kind of walked through initially the first part of the treatment court bill and have just finished that and you're getting ready to perhaps have the staff present the bill in addition to, but if, the two of you have looked at this, and if you've had any questions, please feel free as, we'll call time out here if you'd like to ask questions or comments. Yes.
Mr. Chairman, thank you. Sorry. So obviously a group of us went to lunch together. Maybe our service wasn't as quick as we had hoped, so we apologize.
We're okay.
We're being back, but I did have some comments. I emailed them to you, but I'd like to hear the conversation and the discussion and any public input before I brought that up. Thank you.
Okay. All right. Anna?
Thank you, Mr. Chairman, members of the task force. This bill draft is 25 LSO 029, treatment court amendments. This bill draft was requested by the Supreme Court due to the judiciary taking control of court supervised treatment programs. So starting on page 2, this bill draft allows 2 or more judicial districts to create a regional court supervised treatment program and allows the Supreme Court to create a statewide court supervised treatment program to allow eligible substance offenders to participate. These programs can conduct in-person or remote meetings and may provide teleservices as needed. On page 3, offenders may participate in court supervised treatment programs if they're found guilty in trial. Previously, these offenders who went to trial weren't eligible to participate. And then further down on page 3, juveniles are ordered into court supervised treatment programs rather than having to consent. So that's the reasoning behind the amended language in subsection C there. And then on page 4, a court supervised treatment program may accept participants from any other jurisdiction based upon either the residence of the participant, the jurisdiction where the participant is charged, or the unavailability of a court supervised treatment program in either the jurisdiction where the participant resides or where he's charged. And then on the bottom of page 4 and top of page 5, the public defender is authorized to serve on court supervised treatment programs and diversion program teams and to represent participants in treatment and diversion program proceedings, including sanction and expulsion proceedings. And then this bill draft is effective immediately, and I would stand for any questions.
Please, Senator Boyle.
Thank you, Mr. Chairman. So, and thank you, Anna, for the explanation. One of the comments I heard you mention was about the jurisdictions, and the jurisdictions are judicial district centric. And I guess my query is, when I read Title V and Chapter 12, Title V, this new, which has not taken effect yet, let's just be clear about where we are now in this. Is that actually referenced in the statute, that each judicial district is that's the centrus of a treatment program? Just to be clear, because I didn't find it anywhere, and that was one of the questions I sent to the chairman, was that question. So if it is, just give me the reference, and if you're not sure, we'll belay it and we'll look some more. So thank you.
Mr. Chairman, Senator Barlow, I'm not entirely sure about that, but I can look really quick and probably find the answer. So
if I could, maybe if I could, I'd turn my mic on. Maybe let's go back to Elisa and also to Director Johansson. But the way I see that is those treatment courts do not necessarily have to be in a judicial jurisdiction, but within any governmental jurisdiction. And if that's the case, is that spelled out anywhere, or is that something that perhaps we need to address? Senator Barlow.
Thank you, Mr. Chairman. So, if I could pick up on that, actually, I think that is the question, because the applicant can be one of those other entities, a municipality, a county, nonprofit, et cetera. That's the applicant. But that does not actually, it obviously has a nexus to a service area, but you have judicial districts that are multiple counties. So how does that work? If one county within a judicial district is a participating applicant, if you will, but the judicial district is over multiple counties, that's why I think we have to have a nexus between who the provider is and what the actual authority is, and that's where this multi-county and some of the language, the additional language, that's where I just think I just need to understand it, and I could not understand it based on current statute and the proposed amendments. So thank you, and I apologize for jumping in on Director Johansson.
No, so if thoughts on that, Director Johansson or Ms. Butler, either one?
Mr. Chairman, Senator Barlow, I don't believe the statutes specify in terms of judicial district, and I understand what you're saying. What generally will happen is the treatment court team is made up of people within a location, right? So you have a treatment court judge, you generally have a prosecutor, you could have a public defender, and they're generally from a county. And that doesn't mean that a treatment court team couldn't be made up of others, but that's kind of how it works. And so I think the stickiness, there is some stickiness that would come in with a regional treatment court, and that would be, if you had a regional treatment court, what does the treatment court team look like, right? So which prosecutor serves on a treatment court? Is it both of them? Which public defender serves on a treatment court? Could be both of them. But I think that's a question when that regional treatment court is created, right? So when the applicant comes together or the counties come together and they say, we want to create a regional treatment court, and then they design what that treatment court team is going to look like. So I think, it's not necessarily that the treatment court is within a district. It is, it does report to a court, right? So the defendant goes to court, and then it goes through an adjudication, and then the judge in that court refers that participant to a treatment court, and then they participate with a treatment court judge who is different than the judge who sentenced them. And so I think,
But then, and once they've completed that and the treatment court judge says that they completed it, is there any reporting or response back to the original district court or judicial judge that's required by the person that was in violation?
Mr. Chairman, there is reporting back to the court that originally sentenced the defendant.
By whom?
It would be the treatment court, and
Okay.
if that's the question. I'm not sure where that lives, but I might be able to find it. But there is reporting that goes back, because if a participant successfully completes a treatment court program, they're off of whatever probationary period that was associated with their sentence.
And the district judge, or is it district or circuit?
Generally, it's district.
So then a district judge would there be any reason that he would come in and say, I don't like what you've done, treatment court judge, I'm not going to allow this? I think what I'm trying to establish is, once that it's referred to a treatment court, that they really have the authority and jurisdiction to make the final say, in just reporting that it's been completed. So help me.
And Mr. Chairman, I'll look for that authority, but yes, once that is, once a participant is referred to a treatment court, then that treatment court team generally takes over and they report to a treatment court judge. And if they successfully complete treatment court, then it's reported back to the district court. And what will happen sometimes is, you'll have a participant who violates the terms of the treatment court, and they will come before the treatment court judge, and the treatment court judge and team will make a decision together about how they're going to handle that violation. And sometimes they'll hand them back to the district court and say, this person did not successfully complete treatment court, so district court judge, they're back in your court, and you decide how you're going to further sentence. And that could be they end up going to jail or some other avenue.
Okay. Please.
Mr. Chairman, thank you. I don't understand this part really well, but this kind of is in the same ballpark, but this is on page 4, that subsection E. So you have, theoretically, you could have somebody on the west side of the state ends up in a treatment program, supervised treatment program on the other side of the state, right? And then, can you walk me through how all of that would work? Like, explain how this whole process would lay out, because then you start getting people away from where it occurred and away from their families and all that sort of thing.
Mr. Chairman, Representative Summers, I would say I wouldn't anticipate that we would have participants from the east side of the state participating in a treatment court on the west side of the state. This wouldn't preclude it, so it could happen. But in those circumstances, what I would anticipate would happen is that participant would be able to participate in treatment courts through teleservices. So join treatment court meetings through, a virtual platform. The question that would have to be determined, and so this would be something, again, that I think the treatment court team would have to determine, is how do the services work in that circumstance? So if you have someone who lives in Torrington who is participating in a treatment court in Jackson, obviously the provider is in Jackson, so any services associated with that treatment court, that's something that would have to be determined by that treatment court team.
But I think, in fairness to the speaker's conversation, in my mind, I visualize maybe somebody got picked up on spring break, and then they're going back to Laramie. And the judge may say, fine, you can participate in treatment court in Albany County or in that jurisdiction. And so I could see that distance, you could see some distance related
Yes.
allocation, but they would agree, the treatment court would have to agree to receive that individual from another jurisdiction.
Mr. Chairman, that's correct.
Senator Barlow.
Thank you. And so the jurisdiction, that we're using that term again.
Aye.
And I'm not saying it's right or wrong, but I think there's a couple key decision points here. Someone only can participate if the referring judge and the participant agree to it. So this is a voluntary thing, and it has to have the consent of the court. And the treatment team, which includes the participant judge, has to accept the person as well. So there's actually, there's three things there's three consents that occur before, no matter where they are in the state, or where the crime was, or what your jurisdictions. So I appreciate what the speaker is bringing up, but I think that hopefully self-regulates. We can't adequately treat someone from across the state, or I don't want to go across the state, or the referring judge says, no, that's too far from my courtroom, I want closer. So I think some of that gets worked out. I don't think that answers the question about this regionalization and jurisdiction, and maybe some of this other stuff. You may find a program that is very well regarded, and then how do you actually get there? And a lot of folks are wanting to, and selecting to go there, and then how do you adequately get resources to that particular program while you've got several other programs that have been funded and aren't getting the usage? So how do you adjust that as time goes on? Anyway, I just throw that out there. Thank you.
Comments, questions? Let's go then, with that lively round of debate, let's go to public comment. Any public comment on the treatment court draft that we're considering? Senator Barlow?
Mr. Chairman, thank you. And there were some additions from Title 14 into this statute. I just wondered if Department of Family Services had any comments on those. They're in the bill draft, they are page 3, line 15. These were additions from the juvenile court thing. And I'm not saying that maybe DFS is the right, but they would have oftentimes probably their Chin's case, or there's something going on there. So I just want to make sure. I looked at the references, and I'm not saying there is. I just want to know if they had any thoughts besides what the court brought. Thank you.
So, Senator Barlow, the original language was a little different than that, and we worked with Department of Family Services and to get the reference to Title 14 in there as it is now, to fit appropriately as they deemed. Okay. Okay, public comment going twice, and public comment going 3 times. Thank you. Motion on the bill? Move. Second, thank you. Let's take a look at this bill, and depending on we're going to look at this bill like we did the first bill. If there's some pretty minor amendments, we'll look at it and move the bill. If there's some significant changes, we'll instruct staff to work on that, and we'll look at it at our next meeting. So let's move page 1 and page 2. Senator Barlow?
Thank you, Mr. Chairman. So page 2 brings in some new language under 108. And the reason I flagged this in a note I sent to the chairman, and in the definitions, so in current statute, which takes effect in 104, applicant is a governing body, city, town, county, tribal government, et cetera. And what this does is bring in another 2 or more can provide this service. What is not clear to me, then who is the applicant? Because the applicant is defined in statute, and the applicant is used throughout this, in fact, in this section above. But 2 or more, we don't have a provision. I just want to make sure we understand, do we have a provision that says, is this a joint powers, or is one of them actually the applicant, et cetera? So that's what my question was about this, because it's exactly the same language nearly, except that it says 2 or more. And we're not accommodating that in the definition itself. And I go a step further with this 2 or more. Current statute also says that and there's a little nuance in this, members of the court, the district attorney's office, et cetera, don't have to be employees of the entity, the applicant, but everybody else does. And so now we have multiple potential governmental agencies in this. So how could it be, anyway, so the employee issue and multiple thing. I just want to make sure we're getting what we think we're getting. That's all. Thank you, Mr. Chairman.
So, Senator Barlow, are you saying that we need to refine or clarify who the applicant is as it relates to these governing bodies in G. Am I understanding that accurately?
Mr. Chairman, what I would say is if you take, that we should look at the definition of applicant. And my view is that, and because applicant is used throughout the statute, who is the applicant under the circumstance where there can be two or more? Is it just one of them and now they can work together with someone else? I think they could have done that anyway. So anyway, I just throw that out there. Applicant is defined. And now we're going to have another type of entity who can do these services. What is that? What is the nexus to that? Thank you, Mr. Chairman.
Director Johansson.
Mr. Chairman, I had a similar question, Senator Barlow, so maybe Ms. Butler or LSO could clarify. The way I read this, in trying to resolve that exact same question in my mind, was you potentially had, and I could be wrong, two applicants who were already established as programs that now work independently to establish kind of a joint entity that has a regional supervision program, or Senator Barlow, to your point, maybe one governing applicant that receives certification or an award and then works with this, what would be the second of the two or more governing bodies or entities here. And I think it's a good question, but I didn't read it as, part of the application process that I presumed that it was already, two applicants who were either providing or able to provide these types of services that are now going to separately agree and now have the permission to agree, whether that's through an MOU or a contract, of how they're going to share that power.
So my question would be, forgive me if I'm not tracking completely with this, but there in this new language on G, if you said two or more approved applicants and do away with the governing bodies of cities, towns, tribal government, Arapahoe, because we have the definition of applicants already, does that address it, or
Mr. Chairman, just
give
thinking
me some ideas here on how to fix it?
Yeah, thinking out loud here, I can see it both ways. So you could potentially have two approved applicants that are already established programs. Let's take, Laramie County and Fremont County are going to work together, whatever that might be, and they now have the permission to establish this cooperative agreement to have a regional treatment court. And those are probably two bad examples to use, but I think you understand what I'm getting at. Or you could have an entity that's applying to be a treatment court provider and is the applicant, but has executed an agreement with another provider or entity that may not be an applicant. So I just think maybe some clarity in that language of, I didn't read this as governing the application process. To me, this was either two established entities or one established entity that has a partnership. And so I think that works, but I think it is a little bit confusing.
Senator Barlow?
And so now I'll go a little different route. This would also prohibit implicitly prohibit a single entity from establishing a regional or statewide treatment
Right.
program. So if, let's just take the center of the state, let's take Natrona County. If they had a remarkably good program, they could not accept, based with this new language, if they didn't have a partner in that, another entity, they could not establish a regional or statewide. Implicitly, it's not explicit, but implicitly. Right now, I think it's completely the discretion of the courts through all of the rulemaking authority that the current statute allows them, that they can formulate that however they want. They could say, yeah, this is regional, or you guys sort it out, because they have control of the resources, i.e. the funding, and the applicant process. They are going to approve or disapprove applicants, period. So this is where I don't think this language is necessary. I think the courts could do this without us touching it, if they chose to. They can say, this is a better way to establish, do these things. If we want to do something, we can just authorize the establishment of regional or statewide programs based on the needs of the Supreme Court things, but not get into these other details that deal with the applicant, that deal with all those other things. That's just my thoughts. Thank you, Mr. Chairman.
Elisa?
So, Mr. Chairman, I must admit, I had not thought of Director Johansson's. I think the original intent of this was to allow two entities to come together to decide to create a regional treatment court. And so, but I think it's a really good point that you could have two established treatment courts already receiving funding that want to work collaboratively or together as part of one treatment court. I would say to Senator Barlow's point, the way that so let me go back. I think there are a couple of different things that we could do here. One is to amend the definition of applicant, and so that's in 512-104A Romanet 2. So it reads, applicant means the governing body of a city, town, or county, and then it goes on to say a tribal government of either the Northern Arapaho or Eastern Shoshone tribes of the Wind River Indian Reservation, or a nonprofit organization recognized under a 501c3. So we could amend that to say applicant means one or more governing bodies. So that's a fairly easy change. And so what that would allow is two entities to come together and create that collaboration and then apply as one.
Now, is that in definition, is that what you're flirting with there?
Yes.
Okay.
Mr. Chairman.
Thank
So-
you.
So, Mr. Chairman, I'm sorry. So that's one approach. And I do think that that piece is necessary to allow for the court to do appropriate rulemaking to allow for more than one entity to create a regional treatment court. Because the way the applicant reads right now, it's one. And so it wouldn't allow for more than one. And so I think at a bare minimum, that is necessary.
But could you, to Senator Barlow's point, that it prohibits a single applicant from then having, so you could make the change in definitions, then come back and in this new language, say a single approved applicant or two or more approved applicants could establish a regional statewide treatment program and allow that be for both of them, could you not?
Mr. Chairman, yes, I think that would work.
Senator Barlow, does that get us where we need to be?
Mr. Chairman, I think that the approach to the definition, I think that's fine. I think it's one or more, one being
Okay,
or more.
okay.
I think that's fine. I still don't know, I think that implicitly, let's just take a Fremont County example. If the two tribal governments and City of Lander and the City of Riverton and Fremont County all wanted to come together, they could come together, 5 entities, have some kind of MOU, somebody take the lead, that would be an applicant, and do it. Well, they would naturally be the provider for that county, period. They wanted to take on surrounding counties and other people came on board, they could do that as well. So I don't know that we need, I don't know that we need this regional versus statewide issue in there. I think we can leave it alone. Let the court sort that out between the judicial district and the applicant authority. Because I don't believe that, at least in my community, I don't think Campbell County is going to, which puts monies into the current treatment court system, I don't think they're going to say, yeah, we're going to do this and we want to invite all of our neighboring counties to come in and we're going to take care of it for you too. I just don't think that's going to happen. So I think it's going to be thing. So I think the approach to the definition is fine if it makes sense to our LSO staff. I still think we should have, or I'm still not convinced on the regional versus statewide, if that's necessity at all, personally. But and if you want to allow it, there may be programs established on a regional and statewide basis. That's fine, but I don't think we need to say anything more than that, if we need to say it at all. Thank you, Mr. Chairman.
So, Mr. Chairman, I think we could potentially on page 2, that 512-108G, we could just strike that entirely with the amendment to the definition of applicant. I think that.
Is that your motion?
No, that's not my motion, because I have one more point to make.
Well, is your second motion applicable to this?
It is, and that is
Fine, go ahead.
to Director Johansson's point, and his thought was that, you know, what could happen is two established applicants, people who are already, or entities who have already established treatment courts could decide to come together after they've already established their separate treatment courts. And I think that would create some gray area because they wouldn't be one applicant, they would be two creating a regional court. And so that, to me, is where this subsection G could come in, is if you have two established treatment courts who want to work together collaboratively. They're already applicants under the definition individually, but now they want to come together and pool their resources. And so that's where this subsection G on page 2 could allow for that with some changed language.
So how's that language going to sound?
It was exactly what you said 5 minutes ago, Mr. Chairman. I can't remember what it was.
Mr. Chairman, I got a question.
Please.
So, Mr. Chairman, there's no reason that they could not come back with a separate application, right? I mean, if they're eligible individually, they're still eligible together, they just have to put in a new application. So what's the, what would be the Regis time? I don't know.
Mr. Chairman, Representative Summers, it would be time because we do grant out those funds, for a period of time. And so I think we are moving to a biannual grant period. And so we would be looking at granting out those funds July 1st of this year. And then, the next time to apply wouldn't be for another 2 years as together as one entity. So it would be a timing issue. Again, it doesn't preclude them from planning for it in the future if that's something they want to do.
Senator Barlow?
Thank you, Mr. Chairman. So maybe applicant stays the same. I think we can still accomplish it. We go under program, our court supervised treatment program, because that's also a statutory definition. And it means a local court supervised treatment program. We could say it means one or more local court supervised. And then you have the opportunity to also in the definitions say, look, we can do this, multiple applicants do this, and then current applicants can work together as well.
Mr. Chairman,
Director
I
Jones.
agree with that. I'll obviously defer to the judicial branch on what the preference would be here, because I think the intent is clear of what's trying to occur. I would hate to get in the way with annual or biennial periods that would prevent two courts right now from working together, executing an agreement based on geography or someone's, residence location, not exchanging, resources or making that work. And I think Senator Barlow's solution there in the program section is an elegant one. So that, maybe I'm the genesis of this confusion, so I apologize, but I
So then
do
let's-
think that makes sense.
If we may, Senator Barlow, could you take us back and walk us through what you would anticipate the whole amendment being, starting with the definitions, this new language that's in the draft bill, the G, if that goes away, and your program,
So, Mr. Chairman.
so that staff can track
Yeah,
it?
Mr. Chairman, I'm sorry that for the members of the public and the committee that don't have current statute in front of you, which is not effective until 7/1, by the way. This is the anticipatory statute. Applicant means, and I think what we were talking about is taking the language that's proposed on whichever page we're just on, and just saying, currently it says applicant means the governing body, and I think we're just, applicant means one or more governing bodies. I think that's the entire change to that, potentially, obviously with the concurrence of our staff and the courts. And then if you go down to program, which is another definition under the same title, program, or it's program quote, or court supervised treatment program, in quotes, means a local court supervised treatment program that complies with the rules and regulations of the Supreme Court. This is where I think the court could decide they could do multiple things, but if we wanted, we could just say means one or more means a local or combination thereof that complies with the rules of. So it means a local court supervised treatment program, or, that isn't right. Or multiple, one or more, I guess we just go with the same language, one or more court supervised treatment programs, and I would get rid of local. Strike local and just put one or more court supervised treatment. I don't know if our staff is following that, but
Anna, are you with that? And then what do we do with new language on page 2, lines 12 through 19? Do we delete
Mr.
that?
Chairman, I think it can be deleted based on if those two things are acceptable to the committee.
Mr. Chairman, I agree with that.
Anna, you want to read back what we think we have?
So, Mr. Chairman, for the definition of applicant, it would be one or more governing bodies. And for the definition of program, make it, delete the reference to local, and then just say one or more,
Court supervised treatment programs. The current language is,
court supervised treatment program.
yes.
So, and then get rid of G on page 2.
Second.
Okay. Any further conversation on the amendment? Good work. We're good? So with that in mind, those in favor say yes. Aye. Aye. Those opposed? No. Nay. Nay, whinny. Okay, good.
We're going to hold that over until we see that.
Let's continue working the bill, and then we'll see where that's at. So then on any changes on page 3 that are amendment, go ahead.
Mr. Chairman, just to finish that G, I know the motion struck all of G, but the language on lines 18 and 19 of G talked about in-person and remote and teleservices. I guess I would argue that's unnecessary, I think was unnecessary to begin with, except in the context of maybe what we're trying to accomplish here. But I just want to make sure our folks that are used to this don't think it needs to be brought in somewhere else as a authorization, aside from the court already has a broad authority to do rules. So just, could I, if I don't mind, just follow up on that, Mr. Chairman?
Yeah, go ahead. And I don't think they're prohibited now.
Mr. Chairman, I think it's fine to strike it.
Okay, thank you. Page 3. Page 4. Senator Barlow.
Thank you, Mr. Chairman. So one thing, there's a deferment program in Wyoming statute, criminal prosecution deferment, and it's a different reference than any of these. And since we brought in the guilty thing, which was not included, obviously, verbatim, I just want to make sure are we also saying if you're on a deferred program, can't think of the word. But that's pre-adjudication. So how does that fit in? How does that fit in here with a deferment, which is pre-adjudication? They would not be eligible under this. Is that accurate based on what we have now?
Elisa?
Mr. Chairman, I believe that's correct, that they would be ineligible, but we can verify that with the deferral. Yep.
Senator Nethercott?
That's typically how it works, yes. If you get a deferral, then you're not in a drug treatment program. The drug treatment program kind of works as a deferral depending on the agreement with the prosecutor.
Okay. Please.
Mr. Chairman, I have some unfortunate experience in this. So, but I think even folks that have deferrals have requirements to maintain that, and it is often these type of services. That's my point, is should we be actually including them in this potentially? Because they may be getting the services elsewhere anyway, from a different pot of money potentially. But I just throw it out there. And we don't have to answer the question today, but I'm fairly familiar with some of these requirements. It's been a while, and yeah.
Yeah,
Anyway, thank you.
Senator Nethercott?
Mr. Chairman, yes, I think there's a lot of different information out there, misinformation, and layers of programs on layers of programs within the court system regarding how to handle substance abuse-related offenders. Each community, each county handling it very differently, some of that based on an elected prosecutor within that county choosing to exercise their discretion accordingly, other judges having different requirements for the types of defendants they will allow into their treatment program, and then the different type of probationary requirements associated with that term of treatment or probation or bond, depending on the type of agreement reached between the prosecutor and the court and the defendant. So it's very different in all 23 counties. And I think as the court steps into this space, further conversation and knowledge about that may be obtained.
Mr. Chairman, if I could.
Yes.
I think it's worth maybe us exploring a little bit for the next meeting, if we're not going to finalize this bill here, exploring a little bit, because it would be the district court conference that would be dealing with this, because deferrals can only come from the district court, I believe. Circuit as well? Okay, well, anyway, my experience is only at one, so there you go. So anyway, I just throw it out there that let's make sure maybe there's an opportunity.
Mr. Chairman, there's two types of deferrals in the Wyoming statute. One relates to narcotics type possessions under 35-7-1037, I believe. And then there's another 301 deferral is commonly referred to. That can happen for a variety of types of crimes and beyond substance abuse related convictions. It usually applies to a DUI, but it doesn't have to. And there are different prohibitions associated with that. Those individuals who receive a deferral are not eligible for expungement, so there's a disincentive to have that in the event you ever want to expunge your record, because it will show up as a deferral, and it's kind of just a different varying legal fictions out there for whether or not you have a conviction or you don't, and how that shows up on a criminal history. So there's a lot of changing and moving parts associated with the desire to prevent and help different types of offenders.
So the direction I think we're going to go, we're going to got a couple more pages to go, we're going to get there. We will then let Anna put the bill together, get it out to us, and let it look. Senator, that lets you do a little research on the deferral component, maybe visit with, and see if this is something that, say that again?
Mr. Chairman, I'm concerned that maybe there's not adequate data to make appropriate policy decisions associated with those. To further clarify Senator Barlow's question, those deferrals can occur in both circuit and district courts. Our record keeping associated with both those courts varies across the 23 counties. And so I think it'll be a challenge. Certainly, we can obtain some data, whether or not it's a complete picture and whether or not it is illustrative or helps guide our policy as it relates to these low-level misdemeanants who are consuming these resources. I'm not sure it will be helpful.
Thank you. So, we're on page 4. You done with any further comments on page 4? Please.
Sorry, I will comment on the new language. Page 4 of the bill is the lines 6 through 12. I guess my question is if we change the definitions, why would we worry about the residence of the participant, et cetera, et cetera? Why wouldn't we just put a period after jurisdiction on line 7 and just be done with it? Because as I said, this is still, the court referring judge has to agree to it, the participant has to agree to it, and the program has to agree to it.
I agree.
So I think all we're doing is, yeah, you can go to a different program outside of your jurisdiction with this. And maybe we don't need it, but if we're going to keep this in, I think it's fine to say, yeah, you can take someone from somewhere else. But I don't know we need any of the other stuff, because that's only 3 criteria. What if there's another criteria we didn't think of?
So as I understand your motion, you would say that this new language would read, a court supervised treatment program may accept participants from other jurisdiction, period, and strike the remainder of the remaining new language.
In the state, I think is appropriate.
Jurisdiction in the state. So put the period after state.
Mr. Chairman, I think, to me, that makes sense based on the changes we already made and this 1, 2, 3 list. I don't know how many more other things we could add to it over time. Let's just be done with it. Leave it with the court.
Are you, Elisa?
Mr. Chairman, I think that makes perfect sense.
Okay, is there a second? Thank you. So motion to delete all of to put a period in on line 7 after state, and then delete the remainder of line 7, which is just one word, and delete lines 8, 9, 10, 11, and 12. Those in favor of that motion, say aye. Aye. Those opposed? I heard an fine wasn't an option. Okay. Are we done with you?
I believe you are, Mr. Chairman.
Okay, thank you. I think we've done all the public comment on the judicial stuff. Let's move then to Department of Health with the adolescents with high behavioral needs and talk about where we're at with the RFI that we sent out last year, and then if you would walk us through this insurance conversation that has kind of has surfaced as a result of the conversations we've been having with the providers. Director Johansson.
Thank you, Mr. Chairman. Excited to get back to me after Elisa's presentation.
Could we have you pull that mic just a little closer, please?
Okay. So just by way of background, and I'll ask Mr. Fuchs to come up to the hot seat so we can tag team this a little bit. Just by way of background for the committee, we went through the RFI process, as the task force knows, last year between Department of Health, Department of Family Services, and Department of Education, putting a request for information out on our high needs adolescent problem. As a refresher to the task force, we're talking about 10 to 20 very high needs children at any given time, largely adjudicated or worked through the Interagency Children's Collaborative, or the ICC. And the point of that RFI was to try to solicit input and interest from providers or provider groups on how we could serve those children on an emergency and short-term basis in settings that are more appropriate than jails and detention centers or hospital emergency rooms. And these children are really the tip of the pyramid of acuity when it comes to medical issues, behavioral issues, social issues, and family issues, and really kind of all together. So we went through the RFI process. I think, looked to my family services colleagues, we had 8 or 9 responses, if I'm not mistaken, 5 or 6, I'm being told. And we did, I believe, 5 interviews with different provider that had submitted interest on that RFI. Good discussions, varying costs, varying levels of interest in parts of that problem, what types of children they could and could not accept, exclusionary criteria, which you might remember we put into the RFI as one of the most important factors that is generating the problem we have today, which is exclusionary criteria, both for in-state and out-of-state providers saying no to the departments that are trying to manage these cases, saying no to admissions of these children. So throughout those discussions, an interesting concept came up where we were asking what are the factors of other factors that we might not be considering in terms of those exclusionary criteria, or why these children are difficult to serve and difficult for those organizations to accept. And so I threw out the concept of liability, insurance, and indemnification. And essentially what would occur in sort of provider acceptance of these cases if there was a different scheme for liability insurance that the state could consider. And there was some interest there conceptually, because the thinking was insurance might be very difficult to obtain on some of these highest need children because of behavioral issues, violence, facility damage, and general liability in the malpractice space, where, potentially one legal action or lawsuit could really pose a financial catastrophe or a problem facility-wide or provider-wide in some of these cases. So Mr. Fuchs and I had a very initial discussion with some of our attorneys, as well as A&I Risk Management, just really fleshing out the concept. And when we explained that what I just went over with the task force, and after we defibrillated the attorneys on this idea of changing, malpractice and liability statutes, I thought it was relevant for this task force, and so brought it to the attention of Chairman Larson to really begin the exploratory conversation with some of the provider partners we have, both for these kids and for a variety of other services across Department of Family Services and Department of Health. And I think there's, some level of interest in the concept of what this could look like. With really, if you look at slide number 2 from the Department of Health, the problem we're trying to solve is really right now on the anecdotal side, which I think perhaps we could flesh out a bit today and at our subsequent meetings this summer. But one of the factors driving some of this resistance to accepting or admitting these high needs adolescents could be due to liability based on those behavioral challenges and significant needs of these children. What we're interested in exploring is, what is that liability? Because there's different factors that are associated with both liability and insurance coverage, including damage to property, injuries to staff and other patients, and medical malpractice. So what we've been curious about is how do insurers on the provider side react to this? And really, not to be overly simplistic here, but my question for the public and the provider groups is how big of a problem, how big of a factor is this in the state's challenges with placing some of these children on a temporary basis in a more appropriate setting than jails and emergency rooms? And if it is one of the big factors, in addition to cost, in addition to diagnoses, those types of things that we went over last year, then what are some options that the state, that the legislature could consider, or are there options? And so we just have a few ideas. I'll hand it over to Mr. Fuchs just to give you kind of the bare bones details of what this concept could look like, kind of based on what we do internally with state providers, so state staff that are medical providers or contracted medical providers, and the liability and indemnification sections that are in there that could potentially be explored or maybe modeled a little bit differently in statute language to potentially accommodate this problem that we're trying to solve. Mr. Chairman, happy to answer any general questions on the concept or hand it over to Mr. Fuchs just to give you the rough outline of what we were brainstorming and thinking between health and family services.
Any questions to Director Johansson before we hand it over to Franz? Okay, Franz, welcome. It's good to see you.
Thank you, Mr. Chairman. Members of the task force, my name is Franz Fuchs. I'm a policy analyst in the Director's Office, Department of Health. As the Director mentioned, this is sort of a very small and tailored example to a problem which may not be the real problem. We really want to hear from the providers to what, when we talk about liability and insurance, what is the problem we're trying to solve here? Is it property damage? Is it malpractice? Is it staff injuries? There's a whole, because every one of those might have a different options to really address. So this is really just a toy example to kind of talk about, let's look at maybe medical malpractice in isolation and what could the state do as a potential option. So if you look at our slide deck, starting on slide 4, the basic concept is that we, at the state, we have a self-insured risk pool that we use for a variety of other agencies. And we could basically use that as reinsurance for providers who take high needs kids. So basically the idea is if you are either take a specific child or you are willing to take any child we throw at you, you can be eligible to participate in this pool, in this program.
So if there's an increase in your insurance because you take that 1 or 2 kids, then the reinsurance would apply to the increase that applied to those 1 or 2, right? Not for the total population served by that provider?
Ms. Chairman, I think you could do it either way, right? You could have facility-wide or potentially just attached to these specific children. I think it's, again, a design question for decision makers. So essentially, the idea is you would, there's some amount of risk of malpractice out there for these children. I think the data is going to be very hard to get. These are, tippy top of the pyramid. It's going to be hard to get experience on, the malpractice liability. I think we have very small numbers in this state. So that's going to be one problem, is trying to assess the potential risk out there. But then the idea is, you would expose the providers would be exposed to the left part of that risk. So you would have some kind of deductible or some kind of skin in the game for those providers to try to obviously prevent moral hazard of, here's your free malpractice insurance, right? They would be at risk for maybe say up to $100,000 or up to $50,000 or some deductible. And then between that and some statutory cap, the state would cover that sort of right part of the tail. And then we would cap it at some amount in statute at say $1 million or $500,000, and that would cover, in theory, the remaining possible tail that could go out to a while. Couple caveats: that, of course, would not apply to federal civil rights cases. It could only apply to state, right? And they would be carving out or making a very specific exceptions in state statute for the malpractice associated with these very high needs kids. And then, of course, there would need to be an appropriation probably to fund that risk. But I think because the state is self-insured, we wouldn't be paying a premium. That money wouldn't necessarily automatically disappear as a premium. It would go into a pool, and if there were claims, it would be drawn down, but otherwise it could revert or roll over every year. The precedent we have is in slide 6, kind of an eye chart there, but there's existing statute in 139-110. This is about contracted physicians. So when the state contracts with physicians, physician assistants, nurses, optometrists, and dentists who are providing a service for state institutions or county jails while acting within the scope of their duties, in Section B, it caps the liability malpractice. It basically, we assume their liability as a government entity, and then it caps it at $1 million to any claimant for any number of claims arising out of a single transaction or occurrence not to exceed the sum of $1 million for all claims of all claimants arising from a single transaction or occurrence. So the idea would kind of be building off this statute, not necessarily amending it, but maybe adding a new section in that area to kind of fold in this program.
Mr. Chairman, if I can just add one point there, because I think this is where it's key. And so if you look at 139-110, where we wouldn't want to Franz's point, where we wouldn't want to amend this to include either these providers or this type of program for these kids, is where the attorneys really have heart troubles. And that's because in this section, the representation for the contracted attorneys becomes the state of Wyoming. And so obviously we're not trying to model this exactly, but the concept is similar in that we're already contracting with several provider types and provider groups for adolescent care around the state, whether that's in Medicaid or Department of Family Services or what have you. Where the concept is similar is by nature of that relationship, could something similar to this for state contracted physicians operate where legal defense doesn't kind of enter the fray, but this sort of insurance or reinsurance program capped at certain amounts could provide a better avenue for these providers to have liability coverage. And again, if the extent of this problem warrants it, which we'll hear from the provider groups, their initial thoughts as we determine whether this is worth exploring, could be the state stepping further closer to the table in partnership to say, because you're helping take place these children, we're going to limit some of that exposure or provide some reinsurance on in that area of liability. And as Franz mentioned, there's a couple different ways that could be effectuated. One is on a per child basis, as you mentioned, Chairman Larson, and the other, which we have thought about and tossed around, is if you are a provider, and we know that these providers with facilities, whether it's a residential treatment center or a PRTF or what have you, they have many different service lines, many different types of clients, but potentially as a participating provider that works with the Department of Health and Department of Family Services and Education on these ICC kids, enrolling in that program, potentially you could take this concept and have a facility-wide coverage. Now the rules of the game change depending on where the state would go with that. But I really do think it's dependent on what information we can extract between now and our subsequent meetings this summer on what the extent of this problem is and if this is a factor to try to influence either through state statute or programming. And so I hate to bring the committee that kind of a question, but I will say some of my counterparts in other states, 2 meetings we had over the past 6 months or so, about 20 or 25 directors, I had this conversation with them. And I don't know if this is good news, but it felt like good news that Wyoming's not unique in trying to address this issue in your tip of the pyramid acuity placements for adolescents. And this sort of state insurance or reinsurance, liability reinsurance concept generated a lot of, I think, productive discussion and interest among some of my counterparts in other states where I think others are going to be looking into similar frameworks for this type of safety net population on the adolescent side. With that, I'll kick it back over to Franz with any closing comments here.
Franz?
Thank you, Mr. Chairman. I think at the end of the day, this is just a toy example. I think it's a very niche example. It really depends on what the problem we're trying to solve is, and I think you would be well served by listening to the providers to see, whether this is something that would help them out or if their problems lie elsewhere.
And Mr. Chairman, if I may, because you had asked about, the status of the RFI, and I think that'll dovetail with the next topic, but I think we could probably hit that now because it is relevant. What we are, we have not moved forward with funding or awarding on the RFI. We do have a provider that is very, very interested. We've been working on some of the cost detail with that provider, and this is one of the options you might remember where the state would provide a physical location, the provider would provide all of the staffing and 24/7 care and day-to-day operations. That status right now is highly dependent on funding, and as you all know in the legislature, the ARPA bill that did not move forward essentially put the authority for the remaining ARPA funds into the chief executive's office. And they are working now on determining how those additional ARPA funds would be allocated. That's the next step with the RFI that was conducted last year, is to determine what funding would be transferred to the agencies involved in the RFI, and therefore what could we or should we move forward with. The reason I raise that now, Mr. Chairman, is because this, you'll see in some of the content that we provided you, I think the state has a responsibility, certainly the Department of Health has a responsibility to explore and exercise all options possible before considering a state facility or a state institution, not because we're selfish and we don't want to, staff it and provide those services, but because of civil rights, Olmstead, least restrictive setting issues. This is the reason I really brought this topic to the chairman's attention, is I think we should overturn every stone we can to determine whether it's with our community provider partners or some other, contractor or partner, what possibly could we have in terms of, more community-based, less restrictive settings, including, coming to having analysis on cost, having an analysis like we did last year on the primary diagnoses and the challenges, as well as these insurance and liability provisions, before we just default to, a state institutional setting. So that's really the reason this came to the forefront.
Questions for Director Franz?
Mr. Chairman,
Senator Nethercott?
so I really appreciate the deductive reasoning in the PowerPoint of if this, then that, if this, then that, as a possible solution. So I want to go back that the slide says, if this is the problem, here are some solutions. And so we have to start with the big if about whether or not insurance coverage is contributing to costs. And the answer to that is obviously yes. And it's not that I don't want to hear from the providers, but I already know what the providers are going to say, which is our insurance costs are just really way too high because of these high-risk kids, and it's really a strain on our ability to provide services and interfering with our ability to provide care. So recognizing that, I understand that is the testimony. I would rather get the information from the Department of Insurance about who the limited carriers actually are providing services in Wyoming, because there's likely only one, maybe two, that are willing to do business in this state and offer coverage to providers in this state. And then I want their policy statements, and that can come through the Department of Insurance. And then understand the types of claims that they have received and the cost to provide that coverage in Wyoming as compared to other states. And then we'll see if this is really that type of an issue with them or not. And then talk about potential caps. And I think, just to let you know where I think would be appropriate to go in that realm is rather than granting governmental immunity or trying to fit them into our Governmental Claims Act or even their participation into our state self-insurance fund, that there may just be a statutory cap placed. And that is kind of a very simple but clear and unambiguous solution as to what that exposure may or may not be. And just on the slide, just for my own clarification, and I think it's on slide 5, on the analysis of it would not affect potential federal civil rights suits, that's confusion about understanding exposure to the governmental claims. Private entities are not exposed to federal civil rights suits. Only the government can violate civil rights. And so I think we need to be very careful in understanding how complex these issues may or may not be when we go down into the tort exposure realm. And there are benefits of having private companies provide these public services. That would be one of them, that the state of Wyoming is not exposed to potentially these pieces. And that is to our benefit. They receive guaranteed payment every month as a result of taking care of those state custody patients, right? So I think that we need to be very cautious about assuming that it is the actual problem or it is a solution, but I think it's worthy of consideration. So, Mr. Chairman, just to kind of control potentially testimony and maybe who we call on this topic, I would ask that it's the Department of Insurance concerning those insurance carriers and the actual data there instead of providers.
Mr. Chairman.
So, thank you. But we've reached out to the Insurance Commission when this initially come up. They said they needed to get more information. They didn't understand what challenges the providers were having. We've invited the providers to share with us some of those challenges that they're having. It's important for, I think, the committee, the task force, to understand that I don't think it would surprise anyone that there's insurance pressures currently on the providers and any other mental health or medical provider, but they're not serving the highest needs now, so that the pressures we're seeing for them now aren't related to the addition of these. It's what would the impacts be if we took these higher kids. And so we want to be able to differentiate that just a little bit. There's insurance pressures now, and what would that be, or would it mean total cancellation if we took, because what we've heard in the past is we can't take these kids because perhaps for a variety of reasons, one of which we've identified may be insurance. I think coming back to Franz's question is, what is it that the problem we're trying to solve is, we identified, we talked all last year, we have a gap in our system where we're not taking care of this population that have very high needs, because providers have a right to say no. And then what do we do with them? We don't have anything in place, so hospitals or wherever. And so we've kind of come up with this concept that we look at potentially having a state-run system to manage this group. But what if insurance is a barrier and that was resolved and they could take more of these high-need kids, then that would be less of an impact on this state-run program. And so we're going to ferret through that. Director.
And Mr. Chairman, Thank you for that. And first of all, I agree 100% with Senator Nethercott in the way she described, what's needed. I agree. In fairness to the Department of Insurance and the folks we'll hear from today, it's important to bear in mind, last year with this task force was really the first time the three agencies came together and coalesced this population, defined it, explained the demographics as this is the population we're trying to target and serve because of these issues, these challenges that are presenting themselves. So as Franz mentioned, it's a very niche, top of the pyramid. So even for discussions with insurance carriers, I think it's been difficult to say, as any discussion with an insurance carrier would go, they want to do actuarial modeling on this and see what the risk, how do you quantify that? And that's challenging. So I agree 100%, but I think, we took the first step last year in saying we're really talking about 10 to 20 kids. Here's the primary and secondary diagnoses that we see, the age ranges that we see, the lengths of stay that we're looking at. So to your point, Chairman Larson, I think now that we're kind of putting some program parameters around the problem the state is trying to solve, maybe now's an opportune time to discuss both on the cost side, the operational side, the staffing side, as we've done. What about liability and insurance coverage, where I do think provider input would be helpful. But also to Senator Nethercott's point, I'm naive on what the Department of Insurance would have and would not have in terms of policies and various restrictions of the operators in the state. But again, it brings me back to that original point of I think everybody's naive on this right now because we're talking about a pretty newly defined population and potential program.
I'll just.
Mr. Chairman, if I may, I think one of the distinctions we may want to try to tease out is, to your point, is this a risk that can be priced and we'll see it in a premium increase, or is it something that where the insurers don't even want to bother with it and just cancel the policy? I think that's because we initially thought, hey, this is just a risk that could be priced. When we do this RFI, they'll just build it into their per child rate. And that wasn't the case. When we did these RFIs, it was very difficult to say, okay, hey, load your insurance costs into this rate. And I'm starting to suspect that it's more of the latter, right? It's more of an issue of insurers don't want to deal with it. They have to find very, very specialized insurers to even wrap their heads around the risk because it's so rare. So it may not be just about money. It may be something more structural.
Please.
Mr. Chairman, can you be specific about the type of risk that you suspect they are trying to avoid? What are these diagnoses? What is the concern?
Franz?
Mr. Chairman, Senator Nethercott, I mean, at the end of the day, we have a handful, 20 of these kids. A lot of them are going out of state to very, very specialized facilities. We've heard anecdotally they have to get their, I think I heard an anecdote that someone has to go to like Lloyd's of London to actually get a liability policy. And they, very, very technical, specialized insurance companies that aren't, your State Farm good neighbors there kind of policy. So that's all I meant by that.
Dustin, please. Okay. Look at this. Way to go, Dustin.
Mr. Chairman, some of these students, when we look at the exclusionary criteria, we may be talking about arsonist-based tendencies. We could be talking about low IQ with arsonist tendencies. We can be looking at self-harm tendencies, things like that. Stuff that when we look, these children in these very high echelons may possibly need one or two individuals with them 24/7. And going back to what Franz stated is there very well could be a structural piece to this where the number is so small and the risk is so great that structurally there hasn't been an answer to this yet.
Thank you. So I think we're going to go in, is Mr. Schwartz online? We've asked Andy Schwartz, who we requested that he provide and represent the providers in responding to the needs that they have. And so, hi, Andy, nice tie. Just glad to see you remember how you come before the committees, but just
Do I get to apply, Mr. Chairman?
No, we just want to say thank you for being here. Thanks for taking our crap. So please, we'll turn the time over to you. Thank you for what you've done.
Okay, well, thank you, Mr. Chairman, and I appreciate your comment. My understanding was that the tie was only a requirement of members of the legislature, but I'll try and do better next time. And I just want to start by saying in my conversations with the chairman, he made it very clear that I should try and restrict my comments to liability insurance, and I will try to do that. Although Senator Nethercott kind of threw me off a little bit. So I'm just going to go through my prepared remarks and take questions later. So you all received a letter from the Wyoming Youth Services Association. For background on that letter, the members were asked 5 questions to respond to. The first was, had they received notice of a non-renewal of their insurance policy? Had their premiums changed? Had they been making payments out of pocket to avoid making the claims? Are there having new riders or limits put on their coverage? And are there requirements from the state that are causing them to increase their insurance limits or add coverages? So to summarize their responses, which I assume most of you have looked at, the impacts throughout WISA were significantly higher in the residential treatment centers than in the crisis shelters and group homes. I think that was to be expected. The primary reasons for their insurance problems were claims history, licensing investigations, and then the broader one is that a lot of the carriers are reducing their coverage to RTCs in Wyoming in general, and just saying they're not interested in providing that coverage. I'll get back to that later. And then the third issue that came up, obviously, is costs. And as you can see, especially in the residential treatment centers, their liability insurance has gone up approximately 70% in 3 years, which, even considering inflation, is a pretty high increase. All of the providers at one point or another have been threatened with cancellation of their policies, and it forces them to go back and look for new carriers and renegotiate. And just so you understand, these are bundled policies. I think perhaps Stefan referred to this. Their policies cover professional coverage, general coverage, property coverage, and vehicle coverage. The two that are primarily relate to the high-risk kids are the professional, the liability for their workers, and their property, because there's clearly risk that some of these kids can cause property damage, and it's happened in the past. I will note the members of WISA, they want to provide this service, but they need some assistance in certain ways to make it viable, whether it's understanding of what the facilities need to look like to have these kids there, the additional staffing that might be required, but to the point of this particular hearing, being able to get insurance to cover it. So I spent some time talking to insurance brokers and companies, trying to get a better understanding of what they were doing. And it's clear that some of them are just no longer willing to cover high-risk adolescents in Wyoming and probably elsewhere, but specifically Wyoming, which is a funny concept, but for the moment, I will let that be. One of the comments I heard was that court-appointed sexual offenders or victims are becoming very undesirable in the marketplace. And I think the most important part of that whole quote was in the marketplace. So this is the insurance companies doing what insurance companies do, which is managing their bottom line and not, and looking at what the higher risk policies are that maybe aren't worth covering. Some of it is based on account characteristics, which would be, once again, the type of kids that are being served, the services that are being provided. For example, I know our local provider in Teton County does wilderness activities, and the insurance companies are not very happy about that. They just see it as an added high risk with these kids when they are out in the wilderness for 2 weeks at a time. Then the third thing is claims history and loss history. And this comes down to, it isn't necessarily even loss. It's just reportable incidents or any notification that a claim might have been opened, then creates a problem when they go to renew their policies. As I said, it's a national trend. Rising rates are occurring in all categories of insurance. If any of you have renewed your auto insurance lately, I just did. It was a 10% increase for 6 months. There's articles all over about the difficulties in homeowners insurance. So it's not, we have to consider that it is not just about the providers for mental health. This is a broader conversation. A lot of solutions have come up already from Stefan and Franz. I guess the creation of a risk pool is great. The insurance company, one of the insurance people I talked to specified doing something like that based on the local government liability pool, and which is, I believe, similar or maybe even part of the Governmental Claims Act. But part of that is that every member of that pool, basically, there is an actuarial assessment done to determine how much they have to contribute. And my fear would be that would be pretty high for these high-risk providers. But and I only mention that because I've talked to my couple former colleagues on the Appropriations Committee, and they are not inclined to think that is something that is likely to be seen favorably by the legislature. So the only other piece I'd like to bring up, when you talk about claims histories, there's already a conversation going on between DFS and the providers about the language that DF uses regarding investigations and claims, and whether just because of semantics, they are creating issues in insurance inadvertently that can be avoided by just changing the language. I believe the AG's office does that to a certain extent in terms of requiring certain things in their insurance policies regarding data breaches in their computer systems and bonding for employees. Back to the DFS, though, these discussions are ongoing. I can't see if Roxanne O'Connor is in the room, but if she is more informed on that than I am. And in the interest of brevity, I will stop there and stand for any questions. And also, if you want more information from WISA, let me know about that as well. Thank you, Mr. Chairman.
Thank you. Any questions for former Representative Schwartz? All around good guy. And Roxanne's not here, Andy, but Danielle's here and could perhaps comment on your last point. Okay.
Chairman Larson, yes, I just wanted to thank you, Mr. Schwartz, for mentioning those ongoing conversations. I think for the task force and for the public, we just wanted to kind of acknowledge that we are interested in these discussions. We don't want to get too far ahead of AG advice on this topic, but we're happy to continue those conversations. And that we just wanted to share that not all investigations are created equally. When we think about DFS investigations, and that's why it's important to review the insurance renewal application language specifically. But we're talking about two primary investigations. This might be obvious for those in the room, but one being facility licensing. So investigations for non-compliance of rules. They might be health and safety rules. They might be staffing ratios. And then on the other side, there are investigations from the other side of the agency being child abuse and neglect investigations. For the latter, it's a bit more black and white. I don't think that there's as much flexibility in any of that language. But certainly, Mr. Schwartz, we're interested in continuing those conversations that Roxanne's leading on the side of the investigations for non-compliance of rules. And I'm stand for any questions.
To summarize, our intent with this conversation before we go to public comment was as we look at how the state responds in meeting what we feel is its obligations to provide services to this group of kids who have very high behavioral needs. We want to explore how we can, if it's possible, to better utilize the system we have in place before we create a new system. And if that's not possible, then we're going to do this, we're pursuing the pilot program to see what it would take to administer a new program. And that's the intent. Director Johansson brought up this concern on the Olmsted decision about keeping kids in institutional settings. We just received a document back, I think some of you may have read, about the state of Rhode Island, which was referring these kids. There was a hospital, a designated hospital in Rhode Island that would take this level of kids, but they were leaving them there too long. They were ready to discharge, which is always the risk you have when you establish that type of environment. And there are some penalties, but the bottom line on the article I read is there's just a higher level of scrutiny being placed on these individuals with high behavioral needs. So with that, Ms. Somerville, I think we'd like to hear from you, and then we'd open it up to public comment, if anybody wants to, before we shift gears over to education. Thank you for coming, Andy.
Thank you, Mr. Chairman. Andy Somerville, Executive Director for the Wyoming Association of Mental Health and Substance Abuse Centers. Mr. Chairman, my comments on this topic will be pretty brief. Mr. Schwartz touched on a lot of the same responses that I got from WAMSAC providers that are currently providing services to maybe not the top tier of high-risk youth, although in some cases they are, but maybe the tier just below that. But there were a few other things that we've learned in the last month that I wanted to kind of mention. We have also had providers that have had their insurance policies not renewed. Incidentally, the primary driver behind that has been property insurance, not necessarily professional or liability insurance. It's been two-factor pieces. One is the number of claims, so the providers have started to pay those themselves. But the other piece has been just a giant shift, which we don't need to get into, in national insurance, right? Whereas Hail Alley, what is the AI robot that they input your address now into in the insurance agency say? Are you even eligible to talk to an underwriter? Welcome to the new world of insurance. So that's been a pretty major factor. Vehicle and fleet exposure is the other thing that the providers have had some issues with that contributes to potential cancellation of policies. Although those claims are relatively minor, $50,000, $75,000 of a vehicle is totaled, they tend to be more numerous and it's more exposure. So what the providers have started working on is trying to look at options and manage that within their own business practices. Should they be looking at a self-insurance pool? Should they be looking at other options? There's a lot of those conversations on the table. In terms of looking at in providing an insurance package for these high-risk children. We have done some work in that area. Mr. Fuchs mentioned the Lloyds of London. That came from one of our providers when their policy was canceled 2 years ago because the insurance provider said, we just don't want to operate in this space. Property insurance is expensive. We just don't want to take the risk anymore. They're the provider that got pushed into a secondary marketplace of Lloyds of London. One thing that I will note when that happened is that cost tripled overnight to provide that insurance. So I have a provider that's carrying about $500,000 in premium payments. And to Senator Nethercott's point, I don't want to spend time on cost. It's expensive. It's the cost of doing business at the moment, and we're not the only ones that have that issue. I don't care what type of insurance you have. It's really expensive. But there were some other factors here. So the one piece with these high-risk youth that was interesting is insurance companies are also already requiring specific riders that have to be added to policies when there are any type of medical services provided. So if you have any type of psychiatry within your unit, or it's required as would be with these children, that would require a separate rider to be applied to the policy. They are also almost universally excluding any coverage for any sexual assault or molestation, as was referenced by Mr. Schwartz. When a court-ordered sexual offender comes into the program, that can present certain challenges, and essentially the entity is taking on that insurance risk for themselves, saying we know that there's no insurance coverage if something happens with this particular child, with this particular history. One thing one of the insurance industry experts mentioned to me was one thing that's affecting just the availability and desire of insurance companies to be in the market, and cost, but mainly the desirability to be in the market, is a new concerted effort that's arisen over the last few years thanks to AI and the advancement of technology, where we have law firms and legal firms that are scanning newspaper articles and news of the day in states and regions. And if they see an article that says, hey, there was an incident at this healthcare facility, or this happened here, or this happened in this town, what they're seeing is legal entities mass mailing postcards out to everybody in that community, trying to find some type of information to identify anybody who might have had any interaction with that doctor, with that facility, with that program. And you get a postcard in the mail that says, hey, have you had any, it's like the billboard sign you see on TV, right? Have you had any contact with this establishment? Call us, you might have a malpractice claim. And so the number of malpractice claims, what the insurance experts told me was frivolous, and I'm not an expert in what frivolous means, but what they determined, a multitude of frivolous claims have come into the industry, which again suppresses their desire to be involved in ensuring that industry because it takes up a lot of resources and a lot of time. We did not see any particular issue in, even through the secondary marketplace, obtaining the professional liability insurance. There's certainly a cost piece to it. It can be done, but as Mr. Schwartz also stated, the policies that these facilities buy are not for a program and they're not for a building. They are for the entire entity, the entire 501c3 and program. And so it becomes difficult to the discussion earlier of how do you separate out what the cost and the impact is for this is the program they were running here and now we're adding this on top. I think that would be difficult to quantify. And finally, my last comment would be, Senator Nethercott made me smile with her comments because she went exactly where I was going to go. In all the conversations that I've had, the only thing that I can identify that for sure would be helpful is this potentially the statutory cap. It would stabilize the industry, insurer in primary insurance and secondary insurer companies, what their risk would be in the state of Wyoming to engage in that. We did have a lot of conversations about the possibility of a reinsurance plan or a state pool. There was a lot of questions about how would that work, how would we divide the program up potentially, who would be included in it. So in our conversations, we came back to the statutory cap. And I will close with saying I do have a number of insurance experts that are willing to provide claims data and information to the committee if you so desire. I can certainly gather that up before the next meeting. Mr. Chairman, I would stand for any questions.
Thank you. Any questions
Mr. Chairman?
to the senator who made her smile?
try to keep that going. Could we have that data, Ms. Somerville? I think that'd be helpful.
Yeah, if you would just give that to LSO and we'll
Mr. Chairman, I'd be happy to.
Thank you. Thank you. Public comment?
Mr. Chairman, Tana Howard, Deputy Insurance Commissioner. You guys were talking about me, so I thought I better come to the table. My ears were burning.
We're really glad you're here. Thank you.
You're welcome. We did get some questions from LSO, from Anna, regarding this issue. So it's something we're aware of. What we're really trying to diagnose and why I'm not coming with answers today, I apologize, is because we're trying to diagnose what the risk is, right? There's a lot of different types of liability insurance and different types of policies. We're really happy, of course, to help the committee with whatever we have. If we're talking about medical malpractice insurance, which has a long, hard, just terrible history in this state. Really, we're in a good place now. I'm happy to report it's not a crisis market, but as you know, probably 20, 25 years ago, all of our medical malpractice carriers left the state. We're at a good place right now. Like I said, we have about 6 carriers or so. So if we're talking about medical malpractice insurance, those are easier insurers to poll, right, and get information from. When we're talking about other types of liability insurance, we're looking at probably 800 different carriers, depending on which I'm still, of course, willing to get information, but it's a little bit different for those types of insurance. So listening to the testimony, I writing lots of notes. We'll definitely get with LSO and get more information, and whatever the committee desires, we're happy to poll those insurers.
We really appreciate that because you are the subject matter experts. And Anna, the stuff that you get from Andy Somerville, would you just share with the commissioner and his staff, and feel free to reach out to any of us on this conversation. We're just trying to, as you well understand, try to get it figured out. Any questions, task force? We really do appreciate you being here. Give the commission our best, please.
Will.
Further public comment? Okay. Committee, I think we're going to take a 10-minute break. We're done with this topic. We're done with Department of Health. We're going to come back. This 10-minute break is to ice Mr. Brown. Get his nerves going as he comes before this. We'll be back at 3:40. $310. I said 340. 310. Don't you guys? That's Lander math and Lander timekeeping.
Fremont County.
So we're on to item 6, which is the other, we spent a lot of time on vulnerable adults this morning, which is one of the primary things we really want to talk about, and this is the second one. What are the mental health services, and how do those look inside the K-12 model? And so we've got some information that our task force member, Dustin Brown, is going to provide with us. We appreciate him and Wanda being here today. Would like to turn the time over to him and bring us up to speed on district responsibilities and some of those policy considerations. I think we've all received either electronically, and there's a couple of us that use paper that have their slide deck. So Dustin, please.
Yeah, Mr. Chairman, thank you for your time. Task Force, thank you for your time as well, and you're welcome to the Task Force. With me
Is your microphone on, or did?
It's on. Is that better?
Then get
There we go.
you-
I'll go right here. Okay. What we have today, Wanda and I are presenting, is the K-12 mental health summary from WDE. What we have is we have background, policy, and recalibration are the 3 topics that we're going to discuss. If we could move to slide 3, just as a point of reference, last year whenever I was here with the Mental Health and Vulnerable Adult Task Force, we talked about Wyoming Project Aware. So I wanted to bring and reframe Wyoming Project Aware as a way to level set the current K-12 mental health efforts within the state of Wyoming. What you'll see there is we've got 14 school districts that we're operating 4 different programs over. We have a 2020 project that's in Campbell, Fremont, and Park County School District 1 that provides in-person services within the school settings. Our other projects deliver telehealth services, which the district provides a room with technology where the student can go with the support of the behavioral health partner and receive those telehealth counseling services. So when we go back to that pyramid construct, and we're talking about the pyramid, how before we were talking about the acuity, the tippy top of the pyramid with the 10 or 20 students, what we actually have in our top of the pyramid for Wyoming Project Aware is we have 3 to 5% of students that aren't at the tippy top of the pyramid. They're right below that, and they need counseling services for anxiety, depression, adjustment disorder, various different diagnostic criteria that they can get support in. What we found is Wyoming Project Aware is working. There are some hidden slides in the slide deck that have been left out of the presentation, but they've been provided to the panel or the task force in its entirety. And in there, we've got functional data that shows the increases that our students are gaining as they advance through Wyoming Project Aware. We've built a very specific logic model and theory of change. Our next step is social connectedness. So right now we've looked at functional data, we're going to look at social connectedness, and then we want to look at student outcomes. So chronic absenteeism, we want to look at behavioral disorderly conduct, things like that. That's where we're going as we progress through Wyoming Project Aware. Now, as we advance to the next slide, there are policy considerations, aspects of discussion with Wyoming Project Aware. Something that Wyoming Project Aware has done really well is we've involved parents within our framework. The consent process is consent of the parent, it's consent of the youth that's enrolled in the services, and if those 2 consent processes don't occur, we don't deliver services there. We also empower parents to find resources and make decisions. Students are connected to the resources of support, whether that be counseling, whether that be, if we identify food insecurity in there, we get them those wraparound services that can also support. In the recognition, Wyoming Project Aware was delivered to partner with industry, recognizing that districts only have the capacity and the internal capabilities to provide a finite amount of resources. There is a line where it's no longer within the skill set of the school district and the school setting to provide those services, either due to technical skills within the district or the increased needs of the individuals that are being served by our behavioral health partners. So when we frame Wyoming Project Aware, we're really good at getting students from a point A to point B. Recognition and referral and we move over from recognition and referral to delivery of services. The next slide, Gaps in Wyoming Project Aware, recognizes that we have gaps in stabilization. So when we're looking at Wyoming Project Aware, we're looking at screening, stabilization, and referral. Screening also has a component that's assessment and monitoring. We want to do strength-based assessments that identify where our students can thrive. This lets us recognize the resiliency within our student base. Now, also with the progress monitoring, whenever we see areas we can improve, we want to monitor that progress through improvement. When we're looking at referrals, we have community providers, we have school-based providers. There are some opportunities within the framework of Wyoming Project Aware. Yes, Mr. Chairman.
Would you just briefly tell us what the difference between the two are?
Yes, sorry, Mr. Chairman, on assessment and monitoring?
No, what's the difference between a community provider and a school-based provider?
So when I'm referencing the community provider, I'm referencing partnering with industry. So our partners at WBI, for example, CWCC, our other individual organizations and institutions that partner with us on the AWARE work. I am also referencing with the community provider, I'm also referencing the community mental health centers. That's an area that we are looking to make some progress with now, very fundamental, very early prototype type conversations, but they're, for example, in exploration, we're considering what could possibly work with Care Solace, our care coordination platform, and the community mental health providers. Now, nothing beyond just a, hey, what do you think about this kind of conversation? But those community mental health providers could help solve a gap with Wyoming Project Aware.
And I apologize, I'm still not clear. Is a community provider just a mental health provider that's in the community? And is the school, and the difference between that and a school-based provider is the school-based provider is a district employee, or are they providers that come in and just provide services within the school? Help me.
Yes. So, Mr. Chairman, what we're referencing with school-based providers is counselors. We're looking at the individuals that are filling those LEA level billets. ARPA funds have kind of muddied that water where we have individuals with licensure that work external to the school district that have come in and kind of done some of the same modeling. But that's what I mean when I reference school-based providers, is those individuals that are employed by the LEA. Now, when we talk about stabilization, we've recognized that we're really good at Tier 3, but when we look at Tier 1 and Tier 2, we have very different strengths and weaknesses across Tier 1 and Tier 2. So a reference of Tier 1, a Tier 1 level support may be a suicide prevention training that is applicable to the entire student population or the entire LEA staff population. When we look at Tier 2 supports, we're actually referencing something that targets a subset of that larger population. For example, we could be talking about an anxiety support group, a loss of life support group, a self-harm support group. Those are some common examples of what we would see for Tier 2 supports. Now, with that, we recognize within the AWARE construct, but we also have various MTSS, multi-tiered system of support initiatives that are out there within the districts, and not all are created equal. They have various strengths, they have various weaknesses, they can be created from long-term systems level changes, or they could be something that is short-term gains that we recognize as we progress through that system. So something I wanted to suggest as we're moving through there, that an answer to a systematic level approach to Tier 1 supports, Tier 2 supports, and stabilization could be warranted and could be something that the task force could readily grasp and move forward with. If we move over to the next slide, the next set of slides.
Dustin,
Oh, yes.
before we go to that next slide, this might be an appropriate time for me to ask this question. In the first slide we looked at that had the map of Wyoming, and it showed the counties that we had Project Aware in. were they selected because services were available in those communities? Or outside that, because there is a consideration of how do we get services in all communities? So how were those picked?
Yes, Mr. Chairman, so the counties were selected with the exception of 2020. I actually didn't come on to the Department of Education until after the 2020 cohort was selected. But what we've done is we've gone to those communities and said, how quickly could we get an individual services in these communities? And we went anywhere from 45 days to 120 days. And in some instances, we hit a wall and it was just, I can wait list you and I can let you know in the future when I have availability.
And then would you also remind me in this project, who does the screening?
The screening and referral occurs at the school district level.
By counselors, social workers? or-
Typically counselors and social workers, yes, Mr. Chairman.
Thank you.
Okay, going back to our next slide, slide 13, policy considerations. The next set of slides are going to talk about the counselor to student ratios, stabilization, tier 1 and 2 additional supports, and universal screenings. These are areas that policy could be the answer to supporting and bettering K-12 mental health. When we press forward to slide 14, you'll identify that the student population of 94,000 students equates to a counselor of 1 per 305. And not to read directly from the slide, but when you emphasize the bottom, the American School Counselors Association recommended ratios, you look at a ratio of 250 to 1, 250 to 1, and 500 to 1 when you're looking at the psychologists. Additionally, school nurses are a vital referral source. Going back to Mr. Chairman, your question on the referral sources, school nurses are also a vital referral source with Wyoming Project Aware. We find that the nurses can identify, and oftentimes the nurses will also be doing those screeners that identify those additional risks and those additional needs, or the opportunity to build additional resiliencies within our youth.
So I'd like to go back to conversation last year to review just a little bit. That current counsel, just using counselors, for example, we could use any of them, but we'll use counselors 1 per 305, and the recommendation is 1 250. Is the current ratio just because districts are complying with that ratio? They have the flexibility if they wanted to within them to hire more, which leads to my question. Can we, if we adjusted that to where it's 1 to 250, is there a challenge getting the counselors? Is that one of the challenges we have now in getting that ratio down?
Mr. Chairman, that would be accurate. There is a lack of workforce. It comes with the rural and frontier nature of Wyoming. But in addition, I need to bring up a very important point with the counselors. When we look at 1 counselor to 305 students, we have to keep in account that all counselors are not created equal. We have guidance counselors that are filling these billets, and then we have clinicians that are filling these billets. So when we look at this, the recommendation of 1 counselor per 250 students from the American School Counselors Association, that is actually referencing that clinical type of counselor. So we don't have the necessary reporting mechanism to separate out those counselors, so the best I can currently provide is 1 to 305 students. The 305 is not reflective of clinicians. It's reflective of guidance counselors and traditional counselors.
A combination.
It's a combination of the two.
Okay.
So, Mr. Chairman,
Director.
Dustin, is that fair to say that had we that reporting, we could be closer to that ratio that the lobbying association recommends?
Mr. Chairman, Director, we would actually likely be further from that recommended ratio, because if we have, say, 200 of these are guidance counselor types, we're going to have 100 to a higher population of students because of the guidance counselors filling some of these billets. So it's going to make the ratio harder for us.
Okay, thank you.
Senator Barlow.
Thank you, Mr. Chairman. So if you could, and I'm sorry, I can't remember what the model actually funds for counselors of any description. Thank you, Mr. Chairman.
Mr. Chairman, Senator Barlow, when we look at, I don't have the funding for the recommended, but when we did recalibration in 2020, the recommendation was to move from 180 FTE counselors to 338 FTEs. That, depending on the next set of recalibration, we can help support with data and pieces of that nature with the consultants. But at 338, we wouldn't have been within the ratio that the American School Counselors Association recommends either.
Representative Summers.
Mr. Chairman, thank you. And what we actually did in recalibration was just keep our current policy. We didn't move to what the recommendations were of the consultants.
And current policy is, I think, 2005? Is that correct?
Maybe 10.
10, something like that? Okay. Recommendation. We've had, Speaker Summers, remind me, but it seems like we've had that conversation, and legislatively, we've rejected some of those increases that have been in the recalibration process since that time?
That's correct.
Okay.
In the last recalibration is where the consultants really moved on the counselor issue. So they really increased that ratio. Made it by increased, I guess I mean increased the number of counselors in schools from past recalibrations.
And those were not the guidance counselors, but the clinicians?
They just named them as counselors, and they did not bifurcate that.
I think they're mostly guidance counselors.
Well, they talked a lot about, Mr. Chairman, they talked a lot about, mental health needs, and it was kind of a combination of school psychologists, counselors, and support, I forget what it was, student supports. And those all blended in to create, would have created a lot more resources for K-12 than what we currently have for mental health.
It would seem to me that we would want to refine that to say more the clinicians, because if I'm hearing you right, that it would give us a false sense of accomplishment if they were all, and we love guidance counselors, nothing against them, but from your testimony, what we're really trying to do as we screen and intervene and do that is have some clinician-type counselors in there. So am I seeing that right, Dustin?
Yes, Mr. Chairman, that's accurate. When we look at school psychologists and social workers as well, we've got to realize that when we're out of the ratio for the school counselor or the social worker and the school psychologist, we're also diminishing the services that can be internalized because we don't have the workforce. So it's, counselors provide that frontline defense, but the robust kind of system is really the combination of counselors, social workers, and psychologists. So we kind of have the opportunity to create a care desert in our LEAs without having those, not just the school counselors, but also the social workers and psychologists.
Is this a care desert?
Yes.
Okay. I thought, man, I finally got what he, so just say, so on these, on the social workers, would this include your social workers that are assigned to special education?
Yes.
So all inclusive? Okay, Representative Summers.
So, Mr. Chairman, this is kind of back before session. Current law, this is from Matt Wilmar. The current law allocates counselors at the rate of one position for every 250 middle and high school students. In the 2020 recalibration effort, Pikus and Oden recommended to revise allocation for counselors at the rate of one position for every 288 elementary students. So there was no allocation for elementary students in the past, and then one position for every 250 for middle and high school, with a minimum of one position for each district. So the biggest change in counselors was providing them at the elementary level.
Thank you. I recall. Okay, proceed, please, Dustin.
Yes, when we move, Mr. Chairman, when we move to the next slide, when we look at stabilization, the question is, we can see students within 30 days with AWARE, but what do we do from day 1 to day 30 before we can get them in and get them that tier 3 clinical intervention services? That's something that policy could help support. And with that, creating a robust system of tier 1 and tier 2 supports that provide that intermediate level of triage effectively can get us there. So, what do we do if a student needs support but is not a referral candidate? Again, where I'm going with this is it places the onus back on the school district that is interacting with that youth. We have to have some kind of mechanism that allows us to support those youth when we're awaiting services, or when the services are in kind of a pending or rejected status, or we're unable to contact our family members. About 40% of our families don't return contact with us. We've been able to see about 1,600 students through Wyoming Project AWARE in the 3 years that we've been operational, and we've had about 2,100 referrals in that time.
So Dustin, then if the parents don't respond, or if the parents reject the notion that the child needs a referral, this stabilization component would help internal staff at the school manage that child in an appropriate manner. Is that what you're saying?
Yes, Mr. Chairman. What we see largely is that we're still in the phase with Project AWARE that behavior is the leading cause for referral. So behavioral outbursts, bullying, things like that are some of the indicators. There's the traditional screeners. Whenever a student comes up positive on a depression screener or an anxiety screener or a substance use screener, there's still that traditional vehicle or mechanism for referral, but a lot of our students are still identified through disciplinary or behavioral challenges.
Mr. Chairman, Dustin, in Department of Health land, stabilization means something very specific medically or psychiatrically. Thank you. Could you started answering it a little bit. What does stabilization look like in the school setting? What are we stabilizing? You mentioned a few examples, but I'm just curious what that is.
So, I was really specific in the PowerPoints because I didn't want to muddy the water with, and maybe I could use a different term entirely, but what we're doing is a limited skill set of services that should be within the multi-tiered system of support infrastructure within the school district that allows a limited scope of services until we can get to the true tier 3 clinical intervention services. So de-escalation techniques for the staff. Some of those constructs, talking appropriately, non-judgmentally, things that are already built into the MTSS infrastructure, but based on the local education agency's individual capabilities, may not be within that skill set of that specific LEA.
Just one other bit of information. Current law does not provide for any nurses in the model. And the recommendation in the recalibration was basically, it amounted to 123 FTE. I believe it was 1 per 750 students with a minimum of 0.5 per school or per district. So just so you know.
But it doesn't prohibit them.
Doesn't prohibit them, but doesn't provide the resources.
Maybe.
So there are districts that have nurses, a lot of them, but they have to carve it out of somewhere else.
Majority would be.
I would guess the majority do.
Okay. Okay, Justin, please.
Yeah,
Oh,
Miss-
just a second.
Yes.
Director?
Yes, sorry, I'm slow, so I have to sit and think about answers before asking another question. So you mentioned that 40% of parent contact doesn't happen when we're looking at Project Aware and these different tiered services. So, and you also mentioned that stabilization can happen in that 0 to 30-day period, potentially when you're awaiting that next step. But for my clarification, there's not direct services happening when you're defining stabilization here. It's not direct stabilization services for the student. It would be more techniques for staff to deal with behaviors, de-escalation techniques. I guess I'm still confused on what that is.
Yeah, Mr. Chairman, Director, that actually is going to segue into the next area where we talk about specific Tier 1 and Tier 2 supports that can help with this. Is it, can I kind of hold your question until we get there?
Please proceed.
Okay. As we press into slide 16, the state of Wyoming a couple years ago developed the Thrive Framework. The Thrive Framework is one application that can provide these additional supports for students. But when we look at these, we need short-term, long-term, and system-level changes to truly implement Tier 1 and Tier 2 supports. Because, oh, yes.
Just to help me be sure, so you said that we developed this Thrive. Thrive's the name of this program or whatever it is. Is that in place within our districts currently in Wyoming? Where's that at?
Mr. Chairman, through Thrive, we piloted 6 schools with the Thrive framework, so it's operating in those 6. Currently, it's a resource that anyone can utilize, and WDE will provide subject matter expertise in the execution on. Essentially, it's a framework that teaches resiliency, teaches thinking through decision-making, intuition, all these skills that we want our students to have in order to advance their education and readiness for their future careers.
So this is focused on students. Thrive is directed towards students, not faculty.
Mr. Chairman, that's correct.
I see, thank you.
Yes. And so, Mr. Chairman, when we talk through the Thrive framework, Thrive is, it stands for think through decisions, respect for others, inspire action, value relationships, and elevate oneself. So that's what we came together with for our Thrive framework over the course of these 3 years. The condition for success is, there is a piece for adults, the learning and collaboration for adults. We want that family unit to be front and center as we press through our efforts in this K-12 mental health space. We also have micro-credentials that we've been working on. And Mr. Chairman, Director Johansson, this was actually something I thought about after we talked last time regarding micro-credentials. We do have micro-credentials that are associated with Thrive. But again, this goes back to not clinical skills, but that like the non-judgmental conversation pieces, those skill sets that can help de-escalate as opposed to, advance or trigger additional traumas. Now, when we're looking at Tier 1 and Tier 2 additional supports, there are products that are commercial off-the-shelf products. Some examples of these are the Barr Institute, Character Strong, Kindness Matters. Miss Megan Osmond has been here previously before the Mental Health and Vulnerable Adult Task Force. And what that does is it creates immediate gain for the individuals that use that. Now, when we look at longer term examples, a product like the Barr Institute, when implemented with fidelity and in a reliable construct, it actually drives the prevalence rate down from a prevalence rate of 1 in 5 students, 20%. It can drive that prevalence rate down to somewhere between 8 and 12%. So what you're doing in essence is you're creating a situation that is supportive of the districts managing the internal needs of those students, because you're lessening the number of students that are in that Tier 2 and that Tier 3 category. So you're bringing down the hardship that the district is experiencing, because you're expanding that 80% that's traditionally in Tier 1, you're expanding that closer to 80, 85, 86, 87%, as high as 90% 93%. So you're actually lowering it where within 10% roughly is that area that you really need to focus those efforts and supports on.
So as those of us of a lesser world listen to you talk about all of these programs, we trying to get in my mind, my question would be is do supports like BAR or Kindness Matters work in addition to and enhance, or are they separate than AWARE?
So many of them work within the framework that's already established. So for example, BAR would work with AWARE. If there was no supports, it can come in and fill out the entire support structure. You know, something like Character Strong would support the infrastructure that's already in place. So the various levels of the ability to stand alone, Mr. Chairman, it varies widely depending on the product that's utilized.
Okay.
Okay, as we progress into universal screenings, another policy consideration would be our ability to support our students hinges on our ability to appropriately identify those students. Universal screening 3 times per year, which is the recommended standard of universal screeners, with a conduction with the start of the school year, prior to the December break, and prior to the end of the school year, can help identify the students that are in need. There is a burden to this because, you know, we'd be going from a lot of districts not doing those universal screeners to asking for those to be executed 3 times per year. But truly, if you can't identify the student need, you can't address that student need. We're finding that what are known as kind of the silent sufferers are largely still not identified after, you know, 3 years of work with AWARE. We still have that gap in identification because the behavioral, those pieces kind of rise to the top in the referral process.
So can you I just have this vision of cows running in an alleyway lining up to go to the squeeze chute 3 times a year. And I'm just trying to figure out how this screening 3 times a year, help me. What does that look like? I mean, you go to a school, do you bring all the kids in and
Yeah, so
every
Mr. Chairman.
single one and?
Yeah, the universal screeners are typically 5 questions. They're typically somewhere between 5 and 10 questions, and you get an immediate idea. So you can administer these en masse and start determining if there's additional need for additional screener. The universal screener gets you to a point where you might use a clinical screener like a PHQ-9. So for the masses, you can't do a PHQ-9 for the masses like you would one of these universal screeners. You do the universal screener and then you rely on those ones that are outliers to do additional screening and ultimately make a referral.
So when you do these, I mean, I'm assuming that we do some screening like this currently. Is there any outcry from parents that feel that there's something inappropriate with this type of screening? Do we hear any of that?
Yes, Mr. Chairman, I think right now we actually have an example of that with the Parental Rights and Education bill that came through this last legislative session. I think our districts are still kind of working through with their boards exactly what that looks like, but this would be an opt-in process where traditionally this under the traditional process would be an opt-in for students up to, say, 5th grade, and then an opt-out process for students at the higher grade levels. The current legislation requires that this would be an opt-in process for all students. And that's what I would actually recommend if there was a move forward, because it aligns with the will based on that opt-in process. We would only be able to execute this successfully under that process.
Opting meaning the district, the school board opts in to participate, correct?
The individual families, Mr. Chairman.
Oh, so it would be available, the families would opt in to have their children screened. Thank you.
Yes.
Thank you.
Yes. No, there would be no district-directed universal screeners, it would be available to the families that wanted to utilize the universal screeners is the intention. Then when we advance to slide 18, while WDE is not taking a position on recalibration at this time, we can provide specific information that can support the legislature and the consultants with this work. We have identified previously that to scale Wyoming aware across the entire state would cost approximately $13.3 million per year. Now, with that, going back to school nurses not being accounted for in the model, but serving a vital role, that's information that is readily possible that can support additional decision-making. And then lastly, we have the chart for the 2020 recalibration recommendations to increase the number in the total K-12 funding model. So there is some information we can provide in order to support the recalibration discussion.
Would it be fair to say that nurses would be included in pupil support?
Mr. Chairman, I think that would be an accurate location. Or we've gone through with pupil support and nurses as a standalone. I think they could fit in both locations, just depending on what the ultimate recommendation is.
Okay. Continue.
Mr. Chairman, that's the summary of my presentation. I can stand for any questions.
Mr. Chairman.
Please.
Dustin, more of a philosophical question. So assuming the state moved forward in the recalibration recommendations and assuming the staff were there to hire, right, whether it's in the counselors or the social worker ratios, what types of outcomes would WDE or the districts be looking for to show success? As in, there's a lot of hypotheticals with mental health and science and pseudoscience within the industry on what's effective. So I'm curious from a macro side of things, if hypothetically that were to happen and we had these school counselors and doing the screenings, some level of treatment or referral, what would we be looking for? Is it less critical incidents? How do you measure that, and what would the department or the districts be tasked with evaluating?
Yeah. So, Mr. Chairman, Director Johansson, what we'd be looking at is, based on our theory of change, we go from functional data, which we have readily available, and then social connectedness, and then ultimately getting to those student outcome-based data. So absenteeism decreases is what we would look for as success, a successful measure. Violent incidents being reduced, behavioral incidences being reduced, graduation rates being increased, potentially standardized testing measures increases. That's where the literature kind of takes us as we follow this road across our theory of change.
Follow up, Mr. Chairman.
Please.
On the example you mentioned, because it's something that we're looking at in behavioral health redesign for, again, top of the pyramid in terms of needs, but looking at outcomes for school attendance for that priority population group. So does the education system in Wyoming know or think that absenteeism is related to mental health or correlated to mental health measures? Does that make sense?
Yes.
So, we want to see, presumably, as you mentioned, we want to see it as an outcome of, better, more efficient, more effective mental health services in schools. Therefore, we measure or try to look for absenteeism decreases. But do we know beforehand now that absenteeism is correlated to mental health issues?
Mr. Chairman, Director, the science indicates that absenteeism and mental health have a correlation to it. Now referencing from the perspective, is that a view shared in Wyoming? I couldn't speculate on that piece. I would leave that to our elected officials. on that aspect of it. And I know just anecdotally, I've heard, but a lot of that is my position within WD, that there is a suggestion that behavior impacts attendance.
But it seems if there's an accepted correlation, why wouldn't Wyoming acknowledge that that's a correlation? If I heard you correctly, I think I heard you say we haven't taken a position, but if the science or the understanding from the professionals is as such.
Yes, Mr. Chairman, I think there's a lot of stigma still with mental health services. There's family views, there's religious views behind mental health services. So there's so many additional variables that come into play whenever a family chooses to be part of AWARE or doesn't choose to be part of AWARE.
Well, but we're not saying that because you're absent that you have a mental illness, but we're saying that if you have a mental illness, there's a much larger chance that you'll see increased absenteeism.
And Mr. Chairman, if I can clarify, I think.
Sure.
I guess curiosity in my brain is, does Wyoming, do our school districts, do our schools have an absenteeism problem? Number one, and then what out of that, what's attributed to illness, mental health, social circumstances, et cetera. And I think down the line with those outcomes, right, do we observe, do we measure currently violence incidents or disruptive behavior, those types of things? And I'm not suggesting we do or should, but in terms of measuring effectiveness, that would need to be in place.
Yeah. Mr. Chairman, Director, I think there is consensus that we have an absentee problem. Now, the connection to mental health with that absentee problem, that science is there that supports that poor mental health leads to increased absences within the school setting. But in general, I think we're still at the identification stage of, chronic absenteeism is problematic. What are all the variables that go into that?
Mr. Chairman, thank you. And this is just my observation from what I hear, and I wonder, Director, if there's a possibility you could create so what I hear is there's a lot more kids in crisis. So what does kids in crisis mean, right? If you could define that some way, immeasurably define that, so that that was the same definition across schools, this child is in crisis. And if you ultimately reduce that child in crisis, where they're having, they become non-functional in school at that point, then I think that's a way to measure it. I think the question is, how do you get to a common understanding of what crisis is? And what I hear locally is just, school nurses spending their whole time, or counselors, just with kids in crisis. And so if we can reduce that, then we have gained on that. But measuring that, I think, is important. Trying to understand what that really means is important. And I don't know if that's being done. Maybe somebody out there in the schools can tell us more, like Paige.
Questions, comments? So before we Mr. Klausner, I have one question that the comment that we kicked around last year and this year revolved around the question on what is it that we expect districts to do. And I think we, to some degree, settled. To some degree, settled last year that the expectations were that districts have the ability to screen, to be able to intervene, and to refer. And that proposal or that point of view kind of came up in versus having our districts be mental health providers and increase staff to where they're doing that. And so I, as the chairman and Chairman Baldwin, have kind of proceeded this year with that kind of basic understanding that that's what we would expect our districts to be able to do. And so my question there for the committee is there anyone here that thinks that that's misguided, that we would expect those, that's what the state would expect districts to be able to do? So, or have we missed the boat there?
So, Mr. Chairman.
Please.
So, Mr. Chairman, I think it's student-specific. I think if you look at the program that the AWARE program, right? It was really setting up, it was kind of that way, but it was trying to get that last leg. So who is the provider, and trying to actually connect through telehealth or something with the parental consent to make sure that was happening. And so I think it, stabilization and then referral is true, but there may be that referral may be a connection mechanism that schools provide. And so I'm ultimately, I don't think we want, as little as possible. We don't want children getting just straight out mental health services at a nonstop level, in school. But I think there's probably more than just a recognition and a referral. I think there's got to be some way to connect to ensure that particularly if there's parental approval, to try to get connection versus just referral. But that's just me.
Well, I appreciate that, because I think we all have in our own mind what the definition is, right? And in my mind, the referral process would be that include the connection. But I think more, in more detail, I think we're trying to send a message to the districts that we're not expecting you now to gear up to be having mental health services that you're going to have to provide with it in billing and whatnot. We want them to educate and to be able to identify some of the problems, stabilize them if needed, intervene however we need to, and then refer to where, through the parental consent and through helping them connect with the right services, whether that's through telehealth or with a Project Aware type of environment where those services are available, but not, once those are made, then let our school districts teach. So I just want to make sure that everybody feels that we're kind of on the right track. And if I miss that, and I appreciate those thoughts.
I think, Mr. Chairman.
Yes.
Mr. Chairman, I don't disagree with you, but I think the situation on the ground is more complicated than that. And so I'm not going to say just what that is, but yeah, I don't know the answer to that. I know ultimately a school is going to try to save that child if they can, whatever that might mean. And so I don't know. Like I said, I don't disagree that that's probably the best. Refer, connect, try to help make sure that connection happens, even if it's during school time. But I know in the end, schools are going to try to do the right thing for kids.
Thank you, and I wouldn't disagree, but as we kind of lay a foundation, we have to kind of have some foundational groundwork as we try to identify what then we would provide to the districts to allow their current structure to be identify and to stabilize and to intervene, like this project or BAR or AWARE or whatever. But I just want us to be kind of on the same level as we look out on how we drive this bus forward, that we're not thinking we're going to take the first left rather than go straight. Chairman Baldwin.
Thank you, Mr. Chairman. Just a quick thought is that we're going to revisit this next meeting, and we're actually going to hear something of what Speaker Summers was talking about, and that be some on the ground of what's actually happening out in one of the school districts, where the administrator comes to us and tells us, and it's just one district, mind you, but tells us more what is going on the ground, what's actually happening out there, so you can look forward to that and bring your popcorn.
Thank you. Okay. Thank you. Well done. Wanda, thank you for being here with us. Mr. Kauser, buddy. So while he's coming up there, Mr. Kauser is new executive director at Central Wyoming Counseling in Casper. Chairman Baldwin and I had the opportunity to attend an NCSL conference in St. Louis a few weeks ago, and the highlight, frankly, was, for me, was spending time with Jim, and you have to go to St. Louis to do it, right? But it was really helpful as we brought up this same conversation on if our K-12 system needs services, can the community mental health providers provide those services? And what are some other options that are out there? And so he gave us a kind of an interesting rundown on who he thinks in the state is going to be required in addition to community mental health centers, even with the behavioral health redesign. And he's got some expertise and educated us some on this BAR program, and I've asked him to kind of share that with us so we can all understand that a little better. So Jim, please take the floor, and we'll interrupt you and ask questions as you go.
Thank you, Mr. Chairperson. Appreciate your time and listening and giving the chance to talk about this. Grateful to be here. Not much in show business, so I'm learning here. I think where I'd like to kind of piggyback and dovetail a little bit from what Mr. Brown was sharing is that one of the things as a community mental health or community behavioral health center, when we think about youth mental health and in the school systems, we often escalate it to crisis, or we haven't intervened until then, and then a behavioral health provider comes in and does that. But there are a lot of opportunities before then that we can address it. And I think also in some of the things that Mr. Brown presented, we could see that it's up to a month before a youth is able to be engaged with a therapist. That's too long if they're in need to not have other structured services in place. That many times we find actually reduces the need for the mental health referral at that point. And so by bolstering that stabilization programming model, and I think we also know, I've lived and worked in rural areas my entire career, and we have never been able to hire our way out of these shortages. It's not going to happen when you look at licensed individuals. And so finding ways to not delay service, but create filters that are also have some recuperative value to them or restorative value. So within a system that allows an intervention to really not have a waiting list. It just means there's an escalation in filters of what the interventions are. Solutions that have done that find ways to train the entire school district, but not similar to the ways that we have behavioral health co-response with law enforcement, first responders. We're not asking them to become counselors. It's really more of understanding a triage of how to get somebody into an intervention if they're in crisis. And for school systems to accept that kind of coaching and training, I've seen that the Building Asset Reducing Risk program has had dramatic effects in just reducing the need for additional counselors, because a lot of the issues are being mitigated, and we're building up what are called protective factors for youth that might, in their private life, may not have some of the resources to do that. And so if they're able to access that at school, so for me, it's analogous to school lunch breakfast programs. We've augmented that at times for families that didn't have the resources to have their child with enough nutrition when they come to school. We have families that don't have the resources in behavioral health and resiliency and need some services, and so they can't transmit that within their network. And those youth don't always have mental health diagnoses, but anyone who's without resources, feeling abandoned, being bullied, being harassed at school, at some point they're going to experience anxiety that can mask and look like it's a diagnosis. And so, but often counselors and therapists are not trained to address that component. They're trained in a different way to respond to the presentation of those symptoms. So I would also support the notion that even if we could hire enough more clinicians to fit ratios, that may not be the best person all the time to be engaging that youth. That if a teacher is able to have a relationship that's within, again, guided by evidence within boundaries in their scope, so they're not becoming a counselor. And I've seen that those programs that work best, I think, fit, especially in, families want some autonomy and direction about what their child is learning and what they're being influenced with and informed about in school. And so by working with a structure, we can have some reassurance that it's not a program model that where the teachers are necessarily having value-laden discussions with youth that are maybe contrary to the family's position on things or as was mentioned, faith traditions and things that we embrace. It allows flexibility that those things can happen, and it's really more addressing the ability to escalate a filter system through the school so that school teachers, and so the motto in that group that I'm not affiliated with them, by the way. There's no commission. I've seen it as an off-the-shelf delivery have a dramatic impact in even the first year, and then create a legacy within the school that allows for it not to be related to, well, when this really dynamic teacher retires, all of a sudden this impact on youth goes away. And it levels the field a little bit for also less experienced teachers to be able to have the same resources and drive a structure that supports youth and also has that standard screening piece. I think that's a really relevant point to look at when we look at like primary care integration with behavioral health. When standard screenings were implemented and required at primary care medicine offices, we ended up catching a lot of people that had mental health needs or substance use risk that otherwise would not have been discussed with their primary care doctor, and interventions were able to happen before it led to an emergency department visit or a Title 25 or something to that effect. And that's what we're wanting to create a culture about for youth in the schools is how do we get ahead of, one, promoting socially appropriate and positive behaviors and patterns with youth, and then also catching changes in the youth's behavior or demeanor or signs of asking for help, and then knowing exactly how to transmit that referral from a teacher level all the way through, rather than waiting until they call the caseworker, and then when they get to the youth, they do it, and then they do the referral to the therapist. So it can increase the efficiency as well. So, it ends up there, the motto of BAR is same teachers, same students, better outcomes. And that's an approach I like. I'm relatively, I'd say fiscally conservative, and think that, just hiring more people and increasing a budget does not necessarily impact outcomes. And I think also in our communities, many times, we don't have an influx of population that's coming. So if we're waiting for that before we try to make improvements, we're missing a lot of opportunities to help kids. I'll pause for a moment.
Representative Summers?
Mr. Chairman, thank you. So go into a little more detail because I really haven't read the BAR thing yet. But if it is based on a screener and we're an opt-in, right? And those very parents that are maybe a little more dysfunctional or the family's dysfunctional, they may not opt in because there might not be a parent capable of opting them in. Mm-hmm. So how does this whole system work? And how do you deal with the fact that there's a lot of parents that are not engaged?
Mm-hmm. Thank you, Mr. Chairman, Representative Summers. The screening piece is only one component of it. The BAR model is a systemic model that approaches changing the avenues of access to youth and building relationships in the school. But it provides our educators with the structure to know how to guide those dialogues and how to discuss. So there's a meeting once a week that the teachers have with their students, and they have structured curriculum activities that provide that allow for some. It's not the structured screeners that Mr. Brown was talking about. They're not medically or psychiatrically based, but they are activities that allow for opportunities for youth to say things about wanting some help or needing some discussion or what are their needs. The teacher then can take that on a weekly meeting to a meeting with the counselors and administrators and talk about changes in a youth's behavior or things that have happened, so that we're attempting to catch that again before there's an incident of behavior or more acute symptoms. So the program, to my understanding, is it's a culmination of four factors. One of them is coaching. So all of the trainers for that program are all either active or previously employed teachers. So it's not coming from a counselor direction. So, and the idea that I thought was effective in that, in seeing it from an outside role as the behavioral health provider connected to the implementation, is that they understood the workload teachers had. They understood how to create a strategy so that it's not one more burden for the educator, but it actually enhances everything that they're doing, and so that it becomes a trade-out. And what they found in the qualitative research in interviewing educators is that it's been consistent that they've all said this has improved my experience as a teacher, rather than this is another, here it comes with another burden that you're laying on me to have to do another program or cram this in my planning period. So it would, and the other is there's a curriculum that goes with it, and then there's a structure of administrative policy that also drives having a champion in each school. That would be the coordinator, so that there's someone who's driving the implementation model. But it's very structured and it's off the shelf, so it allows our schools to not have to spend a dramatic amount of time offline or out of the classroom learning and developing and trying to make a lot of decisions. It's a fully researched model that can drive in. There are other models. I would just urge that this committee possibly consider piloting with some of them rather than piecemealing, just because it creates a legacy of both policy and culture that can drive. Then it's not an expense any longer. It just becomes part of the fabric. And so providers like us come into meetings also weekly with the educators, and we're able to then in real time get those referrals rather than waiting on paperwork and another process. And I think with the structuring of it, it prompts people to be on the lookout and continue to look at what are the changes we're seeing in our youth, what are the needs, rather than waiting for quarterly meetings or those kind of things that currently a lot of times in systems it becomes a side note to address the behavioral health issues until there's a dramatic incident or a real problematic one.
Any other questions for Mr. Causer? Please.
Mr. Chairman, just a note, we're thrilled to have Jim at CWCC. It's been a great transition, so appreciate all the work you're doing up there.
Mr. Chairman, thank you, Director Johansson.
He bought a house. It's a good sign. It's a good sign.
Cook.
Yeah. Anything else, Jim? So would you touch slightly, you got really into the bar thing, but just in resources around the state, is it all hands on deck or how?
Yeah, I believe it is. I think that's been a challenge in many states that I've operated in when it comes to the education system, because we do have bills where we're teachers and educators can be really tentative to engage and have some of these discussions because they're worried. They want to protect the rights of the parents. They're trying to do the right thing. And we all, and sometimes, if we don't have a structure, I think that's where it gets dangerous. But if there's an agreed upon structure at the school and the parent is oriented to it and they consent to it, the parent can also feel confident that the dialogue that's happening with the teacher is going to fall within, areas they feel are important for them and it's in the best interest of their child, rather than, a concern that someone might be directing their child to consider different values or, different choices about how they live. So it's more focused on safety and then keeping the educational team in more of their scope, and then knowing better when to bring in the behavioral health team. And there's also structure that there are meetings that happen with the parents and the community, so that the education system is continuing to stay connected to their local community. I think there are a lot of other interventions that work with this and aren't only. I don't think anything's a panacea, but I do think that the structure and protocol-based approaches to things have demonstrated to really be force multipliers for us, in that when people know what the protocol is and know the options, they'll act on them. And as opposed to being, I'm worried about this youth, but I don't know what to do. And so in that way, and it also can also reduce a bit of, let's just call in a therapist every time there's an issue and let them sit down. Sometimes that's not in the scope of the therapist, and they're not the best person to interact with the youth, and they would do a better job with a well-trained peer mentor that's within in the school system. And so we've seen that be really helpful. So in that stabilization period, using peer supports can be vital. There's an active assertive linkage is the phrase that's used in stabilization, where a peer support will connect with a person and they can talk with them and share hope and experience. They can't necessarily do clinical interventions, but sometimes what people need for a few weeks is just the hope that things can get better. And I see what someone else has gone through similar things and they're on the other side of it, and they can hang on while they're waiting for professional services to come in. And many times that then leads to a lot of sort of longitudinal assessment of the youth's needs that can be conveyed to the clinician. So when they meet with them, they've got a more surgical approach to know exactly what would be the interventions that would be more effective. Because I think the desert comment that Mr. Brown made was, I think, apropos, in that when you've got that amount of waiting period in between mental health visits, even the efficacy of the visit is reduced. Even though that clinician might be great, if they're not seeing them at the frequency that the model that they're operating from that's been studied to be effective is in, it's kind of like getting an antibiotic and taking it every other day. It's the dosage of the service needs to be aligned with the research of what's effective. And so sometimes it's better to stagger with a system of escalated intervention so that there's a constant intervention all the time. And then when you get to the clinical intervention, someone's prepped and ready to be responsive to it. And we find adolescents, that's a population with all the developmental things they're going through, that a lot of prep work and coaching can be really helpful for them to learn how to use counseling. And paying counselors to do that prep work is much more expensive than using other paraprofessional roles, and messaging.
So here in our school districts and in our even more rural communities, small school districts, we're really starting to look to and rely on telehealth. In St. Louis, that conference that we attended with you walked down and you've seen, like, I didn't know there's that many mental or telehealth providers. I mean, it was just, and so my question is do you have confidence in that merging profession? And or are there concerns or guidelines that you would anything that you would advise us on?
Yeah, thank you, Mr. Chairman. I do have confidence it's selective in telehealth delivery. I think when we've looked at some studies that have been trying to look at the efficacy of that and the switching, especially with the COVID-19 restrictions in so many states, it really amplified the utilization of telemedicine. And it is an effective intervention, especially for the clinical, psychiatric visits, psychologists, testing, those kind of things. Where we've seen it be most effective is when sort of on the ground with the youth or the client, there is also another trained professional who is facilitating, and it's one of the things that we do in Aware. Our clinicians in the Project Aware they're all telehealth, but they have case managers on the ground at the school that are able to engage with the youth and prep them for that. And again, that's a more efficient way. So training paraprofessional roles, training the teachers and the culture in the school to support the mental health interventions that are happening that might be telehealth, I think is demonstrating to be where telehealth can be very effective. I think if it's just a Zoom call that a youth is using on their phone by themselves and there's not a pre and post prep and interview and some screening and those kind of things, there lends a lot of opportunity for the person to not really engage in it and maybe not interact. I will have to admit, generationally, I did not grow up on an iPhone, so I also understand and appreciate that youth now can determine that there is more opportunity for intimacy through digital contact than I may perceive, coming from my background. But so I think that bodes well for us now too, that as we move into generations that are now 10 and 12 years old, they don't see interacting through a screen necessarily as much different than maybe those of us in a different generation might look at it.
Any other questions? Calvin, welcome to Wyoming.
Mr. Chairman, thank you very much, and all of you in the task force for your time.
Appreciate what you're doing, appreciate the background on some of these things that will help us make decisions. Okay. All right, committee. That brings us at 4:26 to the end. Huh? Oh, public comment. Doggone. So close. Public comment, please. And the doggone wasn't that we're going to have to listen to public comment. It's just that I thought we were there. So, Ms. Simone, welcome.
Mr. Chairman, members of the committee, Lindsay Simoneau with the Wyoming Counseling Association. Just wanting one point of correction that the majority of school counselors, especially those associated with the American School Counselors Association, are not clinicians. That is a very common misconception. School counselors have a different scope of practice. School counselors have a different education tract within the university. We do have a lot of overlap within our education. Ultimately, though, where we separate is within that school counseling and those clinical counseling classes, as well as the internship. As far as what is within the scope of a school counselor, I do not speak for the Wyoming School Counselors Association. I have consulted with them heavily, as this has been a topic now for many years. What Mr. Chairman was suggested from you as far as the foundation of what are you going to require from districts fits within the scope and those tier 1 services that school counselors are comfortable with. When we start talking about long-term groups or any type of long-term therapy within the schools, school counselors and clinicians both get uncomfortable because we recognize that that is when something outside of our scope could be occurring within the school. As far as the presentation given by the good new Wyomingite from Casper, we agree wholeheartedly in that any type of paraprofessional or support staff to help engage these students, as well as increasing the relationship between the school and within those community mental health centers to help those referrals and those handoffs is the best way to address the issue. And yes, we're very excited about the conversation that has happened today. And I stand for question.
Questions? Lindsay, thanks for being here. It's good to see you. Anyone else? Public comments? Ms. Fenton Hughes, how wonderful to see you.
Mr. Chairman, thank you. Paige Fenton Hughes, I'm the superintendent in Douglas, Converse One. I appreciate it. It's good to see you guys. I don't know that I necessarily have any comments, but I would answer your questions. I think Representative Summers, Speaker Summers had a couple questions. I wrote down some of the ones you asked about in the beginning, is it hard to fill our counselor positions? It is. And what we do is we exacerbate the referral issue by hiring people that are counseling our kids in another capacity. So if we have a counseling opening and we advertise that, they might already be working for DFS or, working in the community in some way. And so when we hire them, that just takes away from other services that are being provided to our kids in a different way. I'll just go down here quick. There was a question about, do we have an absenteeism problem? And do we track why our students are gone and whether there's a correlation between that and mental health? I think that was kind of your question. I don't know that we have those exact data, but we absolutely track why they're gone, if it's due to behavior issue or things like that. And we actually have to report all that to the state. So there's a series of reports that we produce. We could drill those data in different ways if there were specific questions, but I'm not encouraging any more required reporting. But maybe if you asked a few of us, we could do that personally for the committee and see what we would find.
So Paige, on that, it's helpful because I think what, particularly as we've tied that to the behavioral health redesign and in the incentivization of deliverables, I think one of the outcomes that we would assume would happen as you address mental health for kids with those issues is that they would be more consistent in their attendance. Are we wrong in that thinking? Are we misreading this idea that if there's anxiety, depression, or maybe some of these other things going on, that there's a tendency that they would miss more school? Are we misreading that?
Mr. Chairman, I don't think you're misreading that. I think if you were asking me to produce a report that tells you that, that could be tougher.
No,
But I agree 100%,
Okay.
absolutely. I believe that we all think if those factors were mitigated, that they would attend more. I don't know that I'd promise you all that, because the reasons we think they don't come aren't always the reason. I will tell you that. And then just to, I think, speak to Dustin's point about the fact that 40% of the parents don't respond, it's going to be hard for us to get parents to opt into screeners. Some of that very consciously because they don't want to opt them in, but some just because they're not responsive to those kinds of things. So we could have, I don't know what percentage, not ever be able to be screened, so that we could do some of the things with regard to early intervention, identifying things earlier on, being much more proactive instead of reactive. I think those problems are going to just be maybe exacerbated a little bit. Let's see. I don't know that there's anything else, any other questions I wrote down, but I would answer any that you all had that I didn't write down and you wanted to know.
Albert?
Mr. Chairman, thank you, and thanks, Paige. You've been kind of at that mic ever since I got in the legislature, and I've always appreciated your opinion. So what do we need to do? You know, from your perspective, from school's perspective, what do you see as something that's needed in this space?
So, Mr. Chairman and Speaker Summers, I would say that some of the things you've talked about and suggested here, like programs. So let me just share from our district perspective. We are trying to do some of that. So give our teachers and our staff members tools to deal with students who come to us with a lot of trauma. So trauma-informed practices. But we are trying to fit that in with new standard sets, which, by the way, we appreciate as well, those pared down standard sets. We appreciate those, but we have to work on them now. And then just all of the things that our teachers are experiencing. So their relationships are key. But maybe the ratio isn't in mental health providers, maybe it's in our classrooms. So if we're gonna, we have a structure that would allow what you all talked about today. So we have an advisory period in our middle school, which, by the way, some of our parents opt out of because they don't want their kids in there. We have, long story, but we have a structure like that at our high school as well. So we could do those things, and I think our teachers would appreciate the support and the training to be able to kind of be in front of helping students before things get to a point where we have to intervene with a counselor. But their numbers are pretty big. And so I don't know what the program looks like. So I'm like you, I haven't read a lot about it. I've heard Dustin speak to it a couple of times, so I kind of know the basis of it. I think having it not feel like one more thing is, and the communication piece would be really big. So some support I think for what that trauma-informed piece looks like would be great, because we're trying to do it on our own now. I think we would welcome partnering with some other districts, maybe in a pilot format, to do that. And maybe that's already going to happen with the Project Aware districts. So I might be speaking out of turn on that. And I think just a recognition about how we talk about what we're trying to do for our kids. And I hope I don't get emotional. Well, I am already. So the stuff that's said about our teachers and our staff members and how we treat kids and what we're trying to do for them comes out like what we're trying to do to them. That doesn't help my staff want to do the things that need to be done. And not because they don't love and care about our kids, but because they're scared. And because we have pieces of legislation that say, this is how you can come after us. This is how you can file a grievance when I'm trying to help your kid. And I know that's not most of your fault in here, but that's a big deal. And I just think, I don't know how we deal with that. But it's hard when that rhetoric is out there for them to take a child under their wing like they know they need to and care about, because 40% of the parents don't respond. And with that said, they're doing the best parenting almost always that they know how to do. They are. There's only a very few parents who don't want to be good parents and don't care. The rest of them do care, but they don't know how to parent. And all of us didn't know how to parent either, right? When we got our kids, we were like, oh, this is how we do it. But some of us had some models, and some of our parents didn't. So we can't blame each other and blame parents and blame schools. We got to get on it together. And this rhetoric about what we're trying to do to each other, again, not blaming, just sharing, is hard. Not something you can probably legislate. So not maybe my best comment to you ever, but support in a way to help us provide some of those things would be well taken.
Please follow up.
Yeah, follow up, Mr. Chairman. So maybe Paige, go back to your brethren, in the schools. And if, we're going to have another meeting, obviously, I hope we have school districts in front of us. But, what are the, top three things that if we can do something, right, that we can do? Obviously, recalibration is, for whatever good or bad, we'll discuss the ratio of counselors. We did do a mental health support grant in the budget, so there is something there. That hopefully that information will be something we can glean from. But I think trying to understand, and this is not just big schools, small schools. What are the 2 or 3 things that we could do that might make a difference that probably we could afford to do and make sense?
Okay. And Mr. Chair and Speaker Summers, I can for sure do that, and I will. I just talked to Boyd on my way over here, and I've been texting Julie, so I think the whole education community will come to you with some things, and thank you for asking for that input, by the way. And I think we're cognizant of the point that just hiring people and, spending money on things isn't always the answer. And so I appreciate the support for maybe a structure and helping our people understand how to provide help in a different way. Because we're doing right now a thing, so how when people leave your organization, you do an exit interview or a survey or something. Well, we have an advisory committee of our staff members, and they said, why don't you do a survey and ask us why we don't leave? Because you're asking all the people why they leave. So we did that. And this issue of dealing with these behaviors is very, very much on our people's minds. And so I think they would welcome some help and support as well, and perhaps see it as a way to make things better.
Thank you.
So setting through this, setting through this task force meeting today, are we having the right conversations or have we missed the boat?
Mr. Chairman, I think you are. I'm not probably the best person. I am, by the way, a school counselor, so that's one of the things I did in one of my degrees. I do think you are having the right conversations. I think asking some school people to weigh in, other than just a couple of us, will be very helpful to you. And maybe we can do some of that in writing so it doesn't lengthen out your meeting ahead of time. We could do that ahead of time. So I'll suggest that. And then I think all of us just appreciate having the conversation, because I feel like if we knew how to solve it, we would be doing it better. And I will be the first to tell you, I certainly don't know. We have an MTSS behavior committee, a K-12 one in our district. They've been working for over a year, and they're working on some structures and ways to help our people. But I think any support they could get would be very much appreciated.
I promise. Well, maybe I'm not going to promise. So Paige, root causes, right, are a lot of things, right? It can be substance abuse. It can be problems in the family. It can be trauma of different kinds, right? So what traumas can we deal with? And I think I go back to the social media thing, and of course, kids are growing up with it now. It's like just part of their life. And I look at what's going on social media, and it's scary. So, some of the root causes, I think when you go back to your folks, besides, what can we do? What are some of the really root causes? And I suspect our professional over there, I'm terrible with names, would understand what the root causes are. And but I think that's important to understand as policymakers is there anything we can do in that space? I know that's difficult, but is there anything we can do in that space to help? Thank you.
Thank you, guys. Appreciate all of you. Yep.
Get ready for our next meeting, posted in Kimmer, and I would just, Kimmer, if you've not made your hotel reservation, you better do it. There's a lot of construction and stuff going on over there, you may not get one task force. And you can stay at Fred's house if there's not any. And one other point is our August meeting, we just sent out an invite. We had it on the day after the primary election, so we moved to be the holiday days. Good catch. I hope that's all right.
Mr. Chairman, Mr. Chairman, members of the committee, we have research that we're supposed to coordinate with DFS regarding what statutes or federal law would be impacted by the confidentiality bill that we looked at this morning. The confidentiality bill has some amendments, so we're going to bring it back to for the June 13th meeting. The same thing for the treatment court bill draft. There's some changes, and we're going to look at it again at the June 13th meeting. And then we have some research regarding deferrals. Do all of the deferrals need to be mentioned within the treatment court bill draft? So we'll look at that. And then as far as liability insurance, we've got an ask to see what other states are doing regarding liability insurance for these types of facilities. And as far as I know, that's the end of our list.
Anything we missed?